Yes, sir. I think we can start. Meanwhile, I'll check with Chetan, sir. It's already 2:10. So,
Dr. Anshul will start. Praveen, Dr. Anshul.
We start.
Dr. Anshul, please.
Okay. Good afternoon, everyone. I extend warm greetings from the office of AMCI Delhi NCR chapter. After a short hiatus, we are back with our second presentation of EBCD. It's one of the interesting discussion on TM joint derangement, and we will get to hear the perspectives from 4 different people this time. One of them being a genuine doctor on the semester, and the 3 others are medical specialists. So without taking or wasting much time, I would like to welcome you all and start the day. Over to Dr. Ashish.
Hi, everyone. Today we are talking on a very important topic, and that is internal derangements of TM joint. We have got 4 very good speakers, very experienced and very good speakers. They are pioneers in this field. We have Dr. Vishal Bansal from Subharti Dental College, Meerut. We have Dr. Chetan Hegde. He is a prosthodontist and he will be speaking on non-invasive treatment in temporomandibular joint disorders. And we have Dr. Nehal Patel. He is a pioneer in arthroscopy, as most of us know. And then we have Colonel Saxena from R&R Hospital, Delhi. We have different topics for all these 4. What I want to mention here is that we will be taking all the questions after all 4 presentations, and you can put your queries in the chat box. Your chat box is open. Queries are welcome. We will have a session on question and answer, and as much as questions you can ask, we will be asking our host and asking our panelists to answer your queries. And after presentations, we will be having 1 or 2 case presentations as well. Those will be covering every aspect of this very complex problem of temporomandibular joint internal derangement. So I would like to introduce first speaker is Dr. Vishal Bansal. He's professor and head Subharti Dental College, Meerut, and he's going to speak on diagnosis and arthrocentesis. Dr. Vishal Bansal, please.
Sir, shall I play? Your voice is breaking, sir.
Please play. Please play Dr. Vishal Bansal.
Praveen, carry on.
Time to speak on diagnosis and arthrocentesis. Internal derangement of the TMJ is a specific term which is generally defined as an abnormal positional and functional relationship between the articular disc and the mandibular condyle and articular eminence. On clinical and radiographically, internal derangement has been subclassified as a disc displacement with reduction and disc displacement without reduction. If you see the etiology can be trauma, which is more common, like microtrauma, malaligned teeth, parafunctional habits, or direct history of trauma. Systemic disorders like autoimmune disorder, Sjogren syndrome, or other rheumatoid arthritis. Other associated factors like stress, joint laxity, and sleep disorders. Nowadays, there are some of the articles which comes with the sleep disorders and association of the TMJ pain. On the basis of the polysomnography, this study concluded that primary insomnia and sleep apnea are associated with the temporomandibular joint disorder. The probable reason for the TMD is that sleep apnea and insomnia may be linked with the central hypersensitivity or pain threshold, low pain threshold, and could be play an important vital role in idiopathic pain disorder. That seems to be a mechanism when we ask for the polysomnography and TMD disorder. If we'll see the other factor which promotes or predisposing to the internal derangement like steepness of the articular eminence, morphology of the condyle and fossa. These all are anatomical changes, generally opens the door for the surgeon. MRI is one of the diagnostic criteria or diagnostic investigation. If we see the normal anatomy, this is the closed mouth position in MRI. Disc is generally located posterior to the articular eminence and appears as a bow tie shape. This red arrow is showing that anterior band and the white arrow is showing the posterior band. And this is the thin bilamellar zone or thin intermediate zone. If you see the open mouth position, the disc thinner intermediate zone, the thinner intermediate zone, which will be the interpose between the mandibular condyle and the articular eminence. This is the normal position of the MRI. You will see the situation of the anterior disc displacement with reduction. In this video, you will appreciate. So this is the disc which is lying in the closed mouth position anterior to the articular eminence. This displacement can be two types, partial or complete. Partial is generally seen in disc displacement with reduction, whereas complete disc displacement is seen in the disc displacement without reduction. Once condyle achieve open mouth position, there is an open disc and open click. So disc will cause in open mouth position, there is an open click. And similarly, when condyle goes into the closed mouth position, there is a reciprocal click. Pain, catching sensation, and deviation on mouth opening due to the inability to the slide smoothly because of increased friction and degenerative changes into the joint surfaces. Ligament generally joined to the disc on the condyle are gradually stretched and mobilize the and graviates the disc in downward and forward direction. So that is the mechanism of the anterior disc displacement with reduction. According to that, we have to manage. This is the another situation where similarly you can see on the MRI, this is the disc which is lying anterior to the articular eminence in the closed mouth position. When we ask the for open mouth MRI, there is a it comes into the normal position. In another scenario, when there is a without reduction, so like this is lying anterior to the articular eminence into the closed mouth position, and similarly it does not reduce, come back, it will be lying into the anterior to that. So this is basically disc displacement without reduction. If you see the examine the MRI, similarly you will find in the closed mouth position, disc is lying anterior to the articular eminence, and in open mouth also this will be anterior to the articular eminence. There will not. So that is patient clinically manifested as a lockjaw, trismus, and pain. These all will be because of there is a complete displacement, there is a exposure of the or there is a degenerative changes into the articular surfaces, which will be progress as a degenerative arthritis. This all has been very well mentioned in the World Journal of radiology, you can refer this article about MRI in temporomandibular joint. How to assess about MRI? So this is the sequence where if you will not miss anything: condyle, glenoid fossa, articular eminence, osteoarthritic changes, loose body generally can seen in synovial chondromatosis, which clinically manifests as a pain, swelling, crepitus, and trismus. Synovial chondromatosis can be two types, primary and secondary. Primary because of chondromataplasia of the disc, and secondary because of osteoarthritic changes. There is a cartilage bodies into the synovial joint or into the upper joint. Hyperostosis, effusion, anterior band disc, intermediate zone disc, posterior band disc. This is the one of the important aspect, angle between the vertical axis of the posterior band. Generally, disc presence of irregular, flat or rounded or perforated disc always indicates the disc disease. The angle between the vertical axis of the condyle and posterior band generally seen as a 11 o'clock or 12 o'clock position. In open mouth position in MRI finding, this is seen generally in cases of especially locked jaw condition or without reduction. Generally, disc will be seen 1 o'clock position. It is a sign of basically locked jaw. Another is a stuck disc. Stuck disc is nothing but immobile disc in open and mouth and closed position. You will see the disc in the same position, which clinically generally manifests as pain, limitation in the translation of the condyle. Yes, dynamic study which helps to understand the patient disc condyle complex. These are the nowadays if radiologists can be performed. This is the dynamic studies where you can understand the basically disc and condyle positions during the opening and closing mouth. Effusion, early joint effusion can be seen surrounding, generally seen an anterior band in the mild inflammatory condition or early condylar in the cases of early TMJ internal derangement disorder. Generally, large effusion when there is a superior joint and inferior joint, you will see the effusion generally seen in autoimmune arthritis like rheumatoid arthritis. When infusion lies the disc, so it is a sign of disc perforation. Generally, TMJ displacement has been categorized thoroughly by the widely accepted staging by the Wilkes. If you'll see the in the terms of arthrocentesis, earlier it was recommended for the stage 2, but over the period, understanding the mechanism of arthrocentesis modification along with the adjuvant therapy, it is nowadays recommended in stage 3, and sometimes it is helpful in stage 4. Further, we will discuss. This is another classification, functional classification of this displacement. It is same like in a Wilkes, but it is clinically oriented when there is a displacement without reduction, with reduction, and there is a morphological grade 3 is abnormal or morphological changes like flat, rounded, perforated. So these are the abnormal discs we can categorize on clinical and MRI finding. Now let's see some of the about arthrocentesis. Arthrocentesis is nothing but it's a physical action of lysis and lavage of the superior joint. So most common disorder is a TMJ, is a non-odontogenic pain in the maxillofacial region. Arthrocentesis is found to be a reliable treatment modality for the patient with internal derangement and inflammatory joint disorders. We'll see the indication for arthrocentesis. It's commonly used for TMJ arthralgia with or without functional disabilities, or anterior disc displacement with reduction or without reduction or with adhesions. Contraindications like patient has a bony or fibrous ankylosis, or patient has extra capsular or other causes of pain like psychogenic, patient not undergone appropriate conservative, non-surgical and pharmacological treatment. Yes, that is the first line of treatment. If not resolved, then we have to think about the arthrocentesis. Basic objective of arthrocentesis is flush out the synovial fluid and inflammatory fluids, provides adequate synovial fluid viscosity, releases of the adhesions by means of hydraulic pressure. These all will decrease the friction between the intra-articular surfaces. Arthrocentesis has been classified according to the technique. One is a double puncture technique. Second is a single puncture technique. Among that, there is two types. One is a single inflow and outflow of the fluid through the same lumen in the only one device. And second is a type 2 is a single puncture technique in which inflow and outflow of the flow fluid through the different lumen only in one device. If you will see the recent meta-analysis by Monitoro, it is recently published in JOMS 2020 and found to be no difference in the mouth opening and operating time in both the techniques. Selection of the fluid, yes, definitely ringal activity is a choice because of it is close to the human serum, better tolerance to the fibrous tissue, and optimize the acidosis into the joint. What is the quantity of fluid? In literature, quantity of the fluid for removal of the biomechanical substances. It varies from the 300 to 100 ml. Giardata et al. Concluded in their study that 100 ml is sufficient for the elution of all these proteins from the joint lavage during the joint lavage. So similar test results are observed. If you see the recent literature, 100 ml is found to be effective for joint lavage. How much pressure should be used? Normally, we use 15 to 20 ml per minute of irrigant is used, and in manual irrigation. Generally, it creates a pressure of around 6 to 8 pK. When there is a severe adhesions, the ureotol use the infusion accelerator for the blood bag and maintain the around 40 K, 35 to 40 kPa pressure for disease of the adhesion and found to be an effective method for removal of the adhesions. If we see the technique, it is under aseptic protocol. Arthrocentesis is safely performed under local anesthesia by auriculotemporal nerve block or with IV sedation. Patient should be seated in a 45-degree. The points of the needle insertion should be marked on the skin according to the Holland and Hessling scale or line. The same described by the Macken also, which is drawn from the middle of the tragus to the outer canthus of the eye. For better palpation, upper joint space, the mandible is displaced downward and forward direction by the assistant, which enlarge the superior joint space. The first point in which mark 10 millimeter from the first line and 2 millimeter below the 10 millimeter of the marking. The second point is 20 mm from the mid of the tragus and 10 millimeter below it. And 18 to or 19 gauge of the needle is inserted into the first mark point and the patient is asked to open and close the movement. The movement of the needle confirms the presence of the needle in superior joint space. Following this, a drop of the fluid is seen into the superior joint space or into the hub of the needle, which is called as a hanging drop method due to positive this so negative due to its positive and negative intracapsular pressure, fluid will come back. That is called hanging drop method. And then after that, second needle is then inserted at the hub of the first needle is occluded to prevent the pressure fall. So patient is again asked to redo the movements, thereby recreating the hanging drop method in the second needle. So this indicates the correct position of the both the needles. So how much will be the depth of the needle? So that is safer by this study CBCT to prevent the thinnest point of the glenoid puncture of the thinnest point of the glenoid fossa. So around 24 millimeter, not beyond that 24 millimeter, 20 till 24 mm is a safe the depth of the needle should be inserted. This is a small video which will be showing. The synovial fluid, which is the lavage or synovial fluid or lavage fluid, should be sent for the gram staining to rule out any septic arthritis or blood cells count or presenters of PMN and LDH. So these will be should be sent for the examination. What is the prognostic significance of the synovial fluid analysis in rheumatoid? They say the high synovial fluid proteins, acid phosphatase, are the predictors of the in cases of rheumatoid arthritis, and they are the poor prognosis in a joint affected by the rheumatoid arthritis. If we see the result of the arthrocentesis, Nitijan first reported the successful outcome of the arthrocentesis in 1991. As of now, 2020, the success of arthrocentesis is still being reported and found to be effective method. If you see that the all studies around 70 to 91.5%. As per literature, success rates in terms of mouth opening, range of mandibular motion, pain on rest, and chewing is reported to be 70 to 84%. But marginal improvement in all the studies, there is a marginal improvement in the deviation on mouth opening and joint noise. So if you'll see the why there is a netizen has reported 91 to 91% reported by the netizen. The only reason he has mentioned about that he used the splint. The reason seems to be that because of use of occlusal splint at least for 4 weeks post arthrocentesis, which prevents the micro trauma and high positive pressure to the temporomandibular joint, which is responsible for the continuous inflammation of the joint. And definitely he will break the chain of the clinching, pressure increase, and hypoxia. So there is no chance of reperfusion. By the giving the occlusal splint, there is a chances of reperfusion or there is a chances of reoxygenation. So that's the reason. That's why he found a good result post in arthrocentesis along with the he used the occlusal splint. This is one of the interesting study by Masaka et al. Concluding that presence of interleukin 1 beta and interleukin 6 in the synovial fluid may be indicators of the possible unsuccessful outcome. If you find lot of interleukin 1 beta and interleukin 6, so there may be chances of unsuccessful arthrocentesis or patient can be have a continue. Generally, these are the factors which are generally seen in the autoimmune arthritis. If you see the complication, there is a hardly complication of the reported in the literature, except there is a temporary swelling, which will be vanished within 24 to 48 hours. Now, what are the adjuvant drugs or with additional drugs can be used? The selection is very difficult to say, but there are some of the drugs like morphine, tramadol, hydrochloride. When patient come with the no anterior disc displacement, only TMJ, arthralgia, morphine and tramadol hydrochloride, even my personal experience found to be effective method because during the one ampule putting in 100 to 200 of ringer lactate and irrigating with that because they directly works on the new receptors and found to be effective in post-operatively improves the VAS scale. Another drug is a corticosteroid. Most preferred choice is a triamcinolone acetonide, which comes in the market as a Kenacort. So it has found as an anti-inflammatory method, especially in cases of pain or long-standing pain or long-standing TMJ arthralgia. Third is a hyaluronic acid, which is also found to be effective in cases of when there is an increased friction, anterior displacement with reduction on clicking and noise into the joint. Fourth is a platelet-rich plasma. These are the post-arthrocentesis can be injected. Hyaluronic acid basically increase the intra-articular viscosity and lubricate, which has been lost due to the inflammation. of synovial membrane. Hyaluronic acid is considered to be a chondroprotective by binding to the CD44 on chondrocyte. CD44 binding is believed to be decrease PGE2 production and increase the heat shock protein like 70 protection. This leads to decrease in all IL-1 and IL-6 expression, which significantly improves the pain-free mouth opening and compared to the alone arthrocentesis. In a study by the Marfinet et al., compared to the various additional drugs, he found concluded that arthrocentesis plus 5 weekly, once in a week, for 5 weeks of low molecular hyaluronic acid injection showed a greater improvement in terms of chewing efficiency, reduced pain, and improves the range of mandibular motion. These all supported by the in orthopedics literature and found to be a chondrocyte. They found to be a chondroprotective and prevents the low some regenerative property as well. Platelet-rich plasma similarly basically to stimulate the hyaluronic acid synthesis to enhance the cartilage production and lubrication. Platelet-rich plasma basically in healing process by delivering a broad spectrum of growth factor like insulin like growth factor, transforming growth factor, which further helps in chondrogenesis, bone remodeling, proliferation, angiogenesis, anti-inflammatory, and cell differentiation, which were observed on 4 weeks by histopathological examination of rabbits in these studies, and clinically also favorable outcome were noticed in terms of joint noise elimination and improvements in the deviation on the mouth opening and lateral excursion as well. Similarly, on this behalf, on this hypothesis, we have conducted in our department, we found the pain reduction and painless mouth opening were better achieved with the arthrocentesis. But joint noise and elimination and correction of the deviation on mouth opening were better achieved with PRP injection because of due to its reparative and regenerative property. I'll show some of the cases. This is the patient complaining of painful mouth opening with open and reciprocal click, mild deviation on the right side. If you'll see the OPG, there is a basically a unilocular radiolucency or bone resorption, which is basically classified as a or described as a any cyst. It's not a true cyst. They are the area of the degeneration and contain fibrous and granulation tissue. A small round radiolucent area with irregular margin. In this case, we have found post-arthrocentesis injection of steroid was performed and found to be effective method. PRP can be considered as a regenerative property. This is the making of basically how to making of PRP. This is the another patient which came with the painful mouth opening, deviation, and difficulty in lateral excursion. Post arthrocentesis, we have injected the PRP, found to be effective method in terms of mouth opening and right lateral or left lateral movements. Basically, lateral movements improved, and there is jaw deviation also corrected over the period. This is the another case of post burn on the face, complaining of pain and limited mouth opening, maybe due to the contracture of the soft tissue, which leads to strain on the temporomandibular complex. Originally, the netizen had described the technique, keeping the fluid generally 6 inches above the temporomandibular joint for continuous irrigation. What personally I found another advantage of this technique is because there will not be change in the position of the needle, because when you will feel the needle and lever the joint, which happen generally in the when you are doing with the syringe irrigation. This is the another case of malunited condylar fracture of the left side with the chief complaint of difficulty mouth opening and pain over the right side of the temporomandibular joint. Further investigation of right temporomandibular joint, there is a reduced interarticular space and there is some fibrous adhesions were noticed. So to remove the adhesion, pressure irrigation was considered, and to that we have just apply the BP cup over the ringer lactate bottle. So for pressure irrigation, generally you can maintain 14 mercury pressure into the sphygmomanometer and simultaneously jaw manipulation to remove the adhesions. Post-operatively, post-arthrocentesis, we have injected the hyaluronic acid, and you can see the suture. In the third day, we achieve a good mouth opening, pain-free mouth opening. Fourth day of the post-operative phase. This is the phenomena basically recapturing in severe adhesions or lockjaw. When you do the under pressure irrigation, there is a remove the adhesion and there is a recapturing of that disc, also reported by the Murakami in his literature. So under when we suspect for severe adhesions, so irrigation under the pressure found to be a effective method. This is another case where there is a patient complaining of pain, flaking, and subluxation of the disc being due to the hyperluxity of the joint. In this case, it is also when there is a post arthrocentesis, we have injected the autologous blood into the superior joint and paracapsular region, and over the period, it is found to be one of the effective method. And the recent article also coming with these conditions with the post arthrocentesis injection of autologous. And it's one of the when there is a laxity of the joint, you have to find higher subluxation of the disc. So it is found to be one of the effective method injection of autologous blood. Long-term studies to be needed to investigate the regenerative properties of PRP in degenerative arthritis like Wilkie's stage 4. Another material which is ELP, that is elastin-like polypeptide, which is coated with the hyaluronic acid. They work as a slow drug delivery system. Over the period, they resolve, and hyaluronic acid will decrease the friction and increase the viscosity. Finally, which promotes the cartilage regeneration. So till date, it has shown the promising result in vitro studies, but definitely in the clinical trial, this is going to be a future into the to correct the especially Wilkie's stage 3 or. Thank you.
So it was a very good presentation, nicely explained. I would request all the participants to kindly post their questions, because I know that you will be having a lot of questions. So I would request you to kindly post your questions here. So next will be by Dr. Chetan Hegde. Uh, he is professor and head Department of Prosthodontics at EBCD Memorial Dental College, Mangalore. And he is very kindly consented to put his views on non-invasive management of temporomandibular joint disorders. I would request now Dr. Chetan Hegde to kindly share his screen and start his presentation. Thank you.
Chetan sir, can you just speak a few words?
I'm audible?
Yes, sir. There is some background disturbance, but rest all things are good. Just
Okay.
put it into presentation mode, sir. Presentation
Yeah,
mode,
yeah.
PPT. Yes, sir. Perfect.
Is it all right?
Yes, sir. Good to go.
Thank you.
Go ahead.
Good afternoon, everyone. It's my pleasure to be speaking to a very galaxy of oral surgeons and the Association of Oral and Maxillofacial Surgeons of India, Delhi and NCR State Chapter. I'll be speaking on non-invasive management of temporomandibular disorders. I would like to start my presentation with the statement: tissues of temporomandibular joint are capable of functional and adaptive changes. Something we need to be keeping in our mind before we can ever think of even attempting a treatment, especially conservative treatment modality with respect to temporomandibular disorders. So today I'll be restricting my presentations only to intracapsular disorders, that is disc displacement with reduction as well as without reduction, and retrodiscitis, because a lot of people do come to us with this acute severe pain due to inflammation of the retrodiscal tissues. I'm quite sure you are aware of. Why? This is the normal joint. There is with the head of the condyle an articular disc coming in between, and this is where the disc is displaced anteriorly. What we are really looking at in conservative treatment aspect is to hold this articular disc back on top of the head of the condyle and allow the retrodiscal tissues to recover. We are just allowing the retrodiscal tissues to recover. We are not trying to permanently recapture the disc on top of the head of the condyle. It is just a facilitative program what we are trying to do. So before you can even attempt a conservative treatment, what are the goals of the conservative treatment option? First and foremost is to decrease the joint pain, increase the joint function and opening, prevent further damage to the joint, and improve overall quality of life and reduce disease-related morbidities. Right? So in the goal, it's very clear, by no means we are trying to recapture the disc, but rather we are trying to ease the situation to the patient so that his quality of life would improve. The various treatment modalities here are intraocclusal appliance, that is orthotic appliance, as well as physical and physical therapy. They always go hand in hand. These are the two most accepted conservative treatment option. You cannot do one and neglect the other. They have to go hand in hand together if you have to achieve good results. And when one is attempting to do a treatment, one always has to keep it in mind. The minimum time required for non-invasive treatment is minimum of 45 days. You need to give this much of time, at least 45 days to 60 days, up to 2 months of time, if you want to see good changes or good results using conservative treatment option. So orthotic appliance is nothing but occlusal splints. I'm quite sure Dr. Bansal and Dr. Nehal knows why I changed why I come out with this particular nomenclature for us. Anyway, disc displacement with reduction. The treatment options available for us is stabilization orthotic appliance and anterior repositioning orthotic appliance. These are the two orthotic appliance that we can think of giving for patients with disc displacement with reduction. Especially stabilization orthotic appliance or stabilization splint, what we commonly refer it as, is indicated when you have a very early click, whereas anterior repositioning splint is indicated when you have a pretty late click. Stabilization orthotic appliance, right, is recommended when the click is within 15 to 20 millimeters or 10 to 15 or 15 to 20 millimeters of opening. That is, as the patient opens, if you can get a click, and if this patient is having pain associated with the click, then stabilization splint would do good. It has to be worn during the night to facilitate recovery and fibrosis of the retrodiscal tissue. What we are looking for is recovery of the tissues as well as fibrosis of the retrodiscal tissue, so that they are made to alter, to bear the load from the mandible. If pain doesn't reduce on daytime wearing, reduce on nighttime wearing, then the patient may be advised to wear the splint even during the daytime for a period of around 4 to 6 hours. That is probably 2 hours in the morning, 2 hours in the night, and all night long. Prevent condyle articulating with well innervated vascularized retrodiscal tissue. This is what any orthotic appliance or a splint, when treating intracapsular disorder, would do. Prevent articulation of the head of the condyle against well innervated vascularized retrodiscal tissue. What the splint would do, it holds the condyle against the avascular portion of the disc and help in recovery of the tissues which are posterior to the disc. So in the early click, as you can see, you get early click somewhere out there, right? The disc is anteriorly displaced. As the patient opens his mouth within 10 to 15 millimeter, the disc gets reduced, right? So this is where we give a splint. On the early opening, in the centric, we give a splint, allowing the head of the condyle to be articulating against the articular disc, allowing the retrodiscal tissues to be free of pressure or free of load, and allowing this tissue to heal or repair. Now there are good options to make an appliance. You can simply ask your laboratory technician to make a SX retainer or a regular orthodontic retainer. Advantage of SX retainer is it's flexible, it is easy for patient to wear, and it is very well retentive. So you place this SX retainer inside the patient's mouth, then mix self-cure acrylic resin, right? After mixing it, allow the polymerization to take place. Once it reaches the dough stage, right? Dough stage, roll the acrylic resin into a rope, right? And just apply it or adapt it on the occlusal surface. Transfer the entire assembly into the patient's mouth and guide the patient into closure in centric, right? Guide the patient to close into centric and make it sure the patient doesn't bite fully. You need to make it sure at least there is the thickness of this appliance is at least 3 millimeters, right? 3 millimeters. And as the acrylic resin sets, advise to make the patient open and close so that this acrylic resin doesn't set around the teeth, right? So that it gets stuck, then you have a lot of problem in your hand. So do not allow it to set completely. As the material is setting, ask the patient to gently open and close, right? Then once the material is about to set, take it out. Once take it out and now allow the rest of the polymerization to happen. So once this self-cure acrylic resin is rock hard, right? Well, you ensure the thickness of this stabilization splint is 3 millimeter. Transfer it back onto the patient's mouth and adopt articulating paper on the right side, left side, including the front portion. Ask the patient to bite through the articulating paper. When the patient opens his mouth, you can see the cusp tip markings out here. It's very essential to get cusp tip markings. All the other acrylic resins, which is anterior as well as posterior, this acrylic resin, hard acrylic resin, is trimmed off, right? So you make it sure the acrylic resin is trimmed off. You may leave some amount of acrylic resin around the canine if you plan to achieve disocclusion when the patient moves to the right side or left side. So by the end of this step, by the time you reach this state, what you have a splint, hard splint, right, which is relatively flexible in the tooth portion, which can be worn easily by the patient, which is at least 3 to 4 millimeter thick, right? And this is where we have provided disocclusion dram. So this the patient has to wear at least for a week's time. If the pain decreases, then the patient can continue to wear for rest of the period of another 3 to 4 weeks time till the patient's pain completely disappears. If the pain increases within 1 week's time, the patient comes back to you, he says, "Doctor, I cannot really wear this appliance, the pain is increasing," then you need to change this appliance into anterior repositioning orthotic device, or in other words, anterior repositioning splint. See, it's an occlusal chip that maintains the mandible in least forward position to re-establish normal condyle disc relation. It is advocated when stabilization splint is unable to provide pain relief. It prevents condyle articulating against the well-innervated vascularized tissues. It is advocated to be worn for a period of around 8 to 10 weeks. First to start, ask the patient to wear only in the night, and if the reduction in pain is not adequate, then you can ask the patient to wear all the nights as well as 2 hours in the morning as well and 2 hours in the afternoon. What are we trying to achieve, right? So if you look into this particular situation, the disc is anteriorly displaced, patient is trying to open his mouth, disc is not really reduced. Disc is reduced when the patient's mouth is completely open, or when the patient's mouth is almost 30 to 40 mm open, the disc is reduced, right? So you really cannot give an appliance or a splint which will hold the mandible in such open position and the patient to be comfortable. Definitely not, right? So what the anterior repositioning splint does is, instead of asking the patient to open his mouth by around 30 to 40 mm, we simply ask the patient to glide his mandible forwards. As the patient glides this mandible forward, the head of the condyle slides down the slope of the glenoid fossa and the articular disc skids, or articular disc sits on top of the head of the condyle with a click, right? So instead of patient opening his mouth wide, the patient is positioning his mandible front, recapturing the articular disc and allowing the retrodiscal tissues to repair or recover. So how to make this? First and foremost, you make a stabilization splint which you already made. You are given it to the patient for a week's time. Patient has worn it. It has come back to you saying that the patient's pain is increased. Now put the same appliance, stabilization splint, back into the patient's mouth. Place your finger against the condyle. I do not have to tell you where to feel for the condyle, right in front of the tragus. Ask the patient to gently move his mandible forwards or protrude the mandible. The point where you can feel the click, that means the disc is reduced on top of the head of the condyle. Ask the patient to stop, right? At this point, ask the patient to slightly open his mouth, place an articulating paper, ask the patient to tap in that particular position. So you know exactly where anteriorly the head of the click has occurred, right? It is marked through the articulating paper. Take a round burr, okay? Take a round burr, make a slot, and make the patient to move his mandible into that particular slot. So patient is moved his mandible forwards and closed into that slot. From this position, you ask the patient to open and close. When the patient opens and closes into this particular slot, feel for the click. There should not be any click at all. That means if you are unable to feel the click, that means head of the articular disc is reduced on top of the head of the condyle. So now what do? Take your acrylic resin, your good friend, mix it. When it's in the dough stage, adapt it on top of this particular splint, and ask the patient to close into the notch, anterior notch which you have created, and allow the material to progress into the stage of polymerization. As the material gets hard, ask the patient to open his mouth, right? Make it sure you don't leave the splint inside the patient's mouth. And ask the patient to open and close. Once the material is set, take it out, right? Take it out, trim off all the excess, right? So the patient knows where. So these indentations of the teeth, posterior teeth as well as the anterior teeth, guides the patient to close into an anteriorly repositioned position where the articular disc reduces on top of the head of the condyle. So this is, you can see, this is a stabilization splint which is advocated, given in centric relation or centric occlusal position, with the splint being around 3 to 5 mm thick, right? And this is an anterior repositioned splint. If the pain doesn't reduce using this, or if the click is pretty late, modify stabilization splint into an anterior repositioning splint. After the pain is reduced, use of appliance needs to be gradually reduced. In the sense, once the pain reduces, then tell the patient to wear the splint possibly only in the night, 1 hour in the morning, 1 hour in the daytime for a week's time. After that, advise the patient, after 1 week, advise the patient to wear the splint only in the night for another 15 days of time. Then probably after another 15 days of time, advise the patient to wear the anterior repositioning splint only once in 2 days or once in 3 days, then you can discontinue. Transient open bite may be seen in the morning after all night wearing of anterior repositioning splint. That's quite common. The moment the patient removes the splint out from his patient's mouth, patient might experience anterior open bite, which will be all right as the day progresses. Physical therapy modality along with anterior repositioning splint is always recommended to enhance fibrosis of the retrodiscal tissue. What the patient has to do? Patient has to wear this anterior repositioning splint, and he has to do hot water fermentation over the joint which is painful. Now what the anterior repositioning splint does, it reduces the articular disc on top of the head of the condyle. So it reduces, it frees the retrodiscal tissue, like it unloads the retrodiscal tissue, and at this position you need to apply hot water fermentation to stimulate, to improve the blood supply of the retrodiscal tissue and to improve the blood supply, to remove the metabolites, and to bring about fibrosis of the retrodiscal tissues, so that when the patient's pain is reduced, the posterior retrodiscal tissue are ready with fibrosis to bear the load from the head of the condyle. That's the funda of entire orthotic appliance. The long-standing chronic patients, it is beneficial to do arthrocentesis to precede anterior repositioning spleen. For a better result, arthrocentesis precede anterior repositioning spleen might give you better results. Following reduction in pain upon using of anterior repositioning spleen, condyle function against adapted retrodiscal tissues. So in case if you have a disc displacement without reduction, then you need to be thinking of using stabilization orthotics appliance, the one which I told you in the beginning, along with manual disc reduction technique, right? What has happened that the disc is completely out, right? Out. So in this case, the results may not really be great. Results is not that great, but you can give it a try. Some patients do respond well. More often they really may not respond that well. In this patient, check whether patient can self-reduce the disc. What you can do is you can guide the patient to move the mandible to contralateral side. If you suspect disc displacement of the right joint, right, ask the patient to move his jaw to the left side as far as possible and try whether the disc is reduced. If it doesn't work then later try manual manipulation. That is, you need to manipulate and teach the patient how to manipulate his mandible in making an attempt to recapture the disc. It is advised in acute disc displacement without reduction. So what you do, how you can train your patient, or how you can possibly do, is make the patient wear the appliance. You can place your thumb on the posterior teeth, apply downward pressure from the thumb, and from the four fingers place it in the anterior position of the mandible and slightly try rotating the mandible upwards. With the thumb you apply downward pressure, with the other four fingers you apply rotational force directing the mandible upwards, right? By this you're forcing the mandible, posterior aspect of the mandible down, and you're trying to rotate as well, and increasing the discal space and allowing a chance for the disc to get reduced. If the patient is lucky, it might happen, but very often it may not really happen. Physical therapy. So these are the various physical therapy modalities: moist teeth, ice application, ultrasound, jaw exercise, cold laser. Out of these, my two favorite are moist heat and jaw exercise. These are something which we need to advise the patient whenever you are adopting a conservative treatment plan. Without this, the result may not really be that great. Very often we fail because we do not adapt to physical therapy modalities. What does the moist heat do? It brings about vasodilatation, it improves the blood flow, removes the metabolic waste products. Peripheral input of heat carried by A fiber masks nociceptive input from C fibers, thereby the pain is reduced, right? It's like cheating. Helps in repair and fibrosis of the retrodiscal tissue. Along with this, what it does, it helps in repair of the retrodiscal tissue. More importantly, it helps in fibrosis of the retrodiscal tissue. If the retrodiscal tissues do not get fibrosed, patient will come back with pain very soon. Very soon the patient will come back with pain. So moist heat modality along with anterior repositioning or stabilization spleen is a must. How do you do this patient? How do you advise? This can be done as a home care treatment modality. Ask the patient to boil water. I don't know how it works in Delhi because it's quite cold now. but otherwise in down out here in south coastal area, we ask the patient to boil the water. Once it reaches the boiling state, we ask the patient to cool the water for around 10 to 12 minutes. In 12 to 12 minutes, if the patient allows the water to cool down, it reaches around 60 degrees centigrade. Then ask the patient to take a white square towel, immerse it in water for 3 minutes, then squeeze the water out, then fold it into a square form, probably make it into 8 folds, square it into a square form, then apply this on top of the joint continuously for 15 minutes. Continuously for 15 minutes. That is why the patient needs to cool the water for 10 to 12 minutes, because if he immerses the towel inside the boiling water, the water temperature is too hot, too much for the patient to bear. So if a patient is unable to bear the temperature, then he is not going to keep the towel there. He's going to remove it within 1 or 2 minutes. No, the patient needs to keep the towel continuously for 15 minutes so that the heat from the towel dissipates through the skin into the deeper tissues continuously over a period of 15 minutes of time, so that heat reaches the deeper tissue, thereby performing what it's supposed to perform. So patient needs to do minimum twice, once in the morning, probably after breakfast, once in the night just before going to sleep, wearing the splint, either anterior repositioning or stabilization, right? So minimum 2 times. If a patient can repeat it 3 times daily, it's very good. So after 1 week, along with hot moist heat fermentation, you need to advise the patient to do resistant exercises, at least 10 repetitions of exercise 3 times daily. This does wonders, because what happens is, we very tend to forget, patient is being, intracapsular patient comes to us over a long period of pain. So he is unable to use his jaw well. So the muscles have become weak. A weak muscle cannot perform well, especially with respect to the pain, right? So we need to reinforce, we need to re-strengthen the muscle. That is why resistant exercise against the pressure and the lower border of the mandible, the patient can place his palm and ask him to open his mouth against the pressure. Any kind of resistant exercise, resistance against opening is the best, for at least 10 repetitions 3 times daily. Then you can increase the repetitions, or you can increase the number of exercises as well, right? It does the muscle strengthening. It helps also in relaxation of the muscles. Ice application, it helps in relaxation of the muscles and also brings about reduction in pain. Ultrasound induces pain in the deeper tissues. It helps in bringing about repair, as well as it breaks down the fibers. It breaks down the fibers and thereby improves extensibility of connective tissues. Patient education, tell the patient to eat soft food, slower chewing, small bites. Eating from the front teeth should be completely avoided. No wide yawning, and tell the patient not to allow the joint to click. These patients very often have got a tendency to check for the click, right? Tell the patient not to do that, right? So I kept my presentation very brief because it's a conservative management. It's good to do it. It takes around 2 months of time. Both the patient as well as the dental surgeon needs this patience. TMJ is capable of undergoing functional adaptive changes. Goal of the treatment is to reduce pain and improve functional comfort. It is essential to understand functional aspect of intracapsular disorder to render appropriate treatment. Conservative treatment is often successful, but it is time dependent. So even after a period of 2 to 3 months, if the patient is not responding favorably, then surgery is the only option possibly the patient is left with. Thank you.
Thank you, Chetan sir. It was a wonderful presentation. I think people had a lot of questions, but most of them have been answered by your presentation already. But
Thank you.
be there, sir, for some more question and answer after all the presentations. Thank you so much for your
Yeah, sure,
presentation.
sure, sure.
So
My
next,
pleasure, always. Thank you very much.
thank you. So next in line is Dr. Nehal Patel. He is a pioneer in arthroscopy in India. He's from Surat. He's a director of ABMSS Center for CLEP at Surat, and he does quite a bit of arthroscopy work. And it is a pleasure because he's a very good old friend of mine, and his presentation is always wonderful to see and hear. Dr. Nehal Patel, please.
Thank you, Dr. Asis, and thank you, EOMSI Delhi NCR chapter for conducting this wonderful seminar on TMJ. Arthroscopy. Before that, I would like to thanks Dr. Vishal and Chetan Negre, especially Dr. Chetan Negre, because he has summarized nicely what has to be done, because there are a lot of misconceptions about the internal rearrangement, and I mean, in 2020 also, it's like an enigma. So to summarize Dr. Chetan Hegde's lecture, what he tried to say is, it is not necessary to bring the anatomy of the joint normal, but it is necessary to bring the function of the joint normal. And TMJ is very adaptable. It is very adaptable. So before jumping to any surgical procedure, we have to try all the method which can bring the function of the joint normal in terms of either physical therapy or conservative therapy in terms of splint. So it is more of a team approach. And there are a lot of questions regarding the treatment algorithm according to Wilkes classification. I'll try to explain in very brief. So this is basically a Wilkes classification, as we are aware of, and see it's like in very early stage when there's a painless clicking or no restriction. Now, first thing we have to understand as a surgeon is we don't have to get fatigued by seeing the patient which are not ours. That means don't try to treat patients of MPDS or maybe myositis. You start scrutinizing those patients. We can treat only 15% of all TMD patients as a surgeon, because rest all of them they require just either sort of physiotherapy or maybe conservative treatment. The patient who are not improving, and that too only internal derangement, if they are not improving with the conservative treatment, then that they come to us, and then we need to provide them a service which we are best at, from either surgery or minimally invasive surgery. So don't waste your time in or get fatigued, because if you start treating those patients of MPDS and myositis, your clinic will be full at one day, and you'll be seeing more of atypical pain or diffuse pain rather than seeing a specific TMJ patient. So start scrutinizing. It's very easy. I'll show you few of the tests which can show you that this is my patient, and this is the patient which may require surgical intervention in future if conservative treatment doesn't work. So if you see the Wilkes classification, the early or painless clipping, there is no restriction. Patient may come just with the pain in the periodical region. I mean, if you take MRI in this patient, all the osseous, even the structure will be normal. Patient who comes with synovitis or early synovitis, if patient do not restrict their movement, if you see the etiology of this patient, they may come with some sort of traumatic history, like they popped open their jaw during eating something very hard, or maybe trying to yawn, or maybe they try to eat pani puri, say, and so the retrodiscal tissue get stretched, and it start the inflammatory process there, and they develop pain. The best treatment for them is the restriction of movement. Just ask them to restrict the movement. And since this is an acute inflammation, I would prefer to apply ice rather than heat application, because the ice works best when there is acute inflammation set in the joint. 15 days of ice application with some sort of anti-inflammatory takes care of their pain. You don't require anything else further. Wilks 2 is early or immediately. Now this is like the Wilks 1 patient has moved forward and they did not take care, and say since 2 or 3 months, it is like a twisted ankle. A patient has twisted, they are walking on the road and they have twisted their ankle, and they are running on the same ankle for another 3 months, and they expect that now my pain should go in a week. That is not going to happen because the ankle is twisted, the ligament has been stretched, so it will take some time. So so the Wilks 1 patient, when they move to the Wilks 2, now the treatment algorithm changes, like what Dr. Chetan Hegde suggested. You give 8 weeks of physiotherapy along with the conservative treatment. So this two patient definitely uh, uh, falls or get treated with the conservative treatment. And as he suggested, the joint is very adaptable. And if they take care, even if the disc is slightly displaced, eventually the retrodiscal tissue become fibrous, and then that acts as a pseudo joint. So after 8 weeks of physiotherapy and conservative treatment, if Wilks 2 patient does not respond, or maybe say there is a pain in the joint, now how do you decide that you should further proceed for the arthrocentesis and arthroscopy? It's a very simple test. It's called Mahan test or load test. So what you do is you put a wooden stick on the premolar and ask the patient to bite lightly, very lightly. Now, if say patient is biting on the right side and patient complains of pain on the left side, that is the contralateral joint. That means patient is loading the joint and patient is actually hitting the retrodiscal ligament. If there is a pain on the contralateral side, that means the pain is coming from the joint. Same thing, ask the patient to move the jaw on the lateral extrusion. The patient is moving the jaw on the right side and patient has a pain on the left side. That means the patient is trying to glide the condyle on the glenoid fossa, and in that process, he is hitting the inflamed retrodiscal tissue and causing pain. So that's the joint pain. And now there is last test which all of you should do before you proceed either with the arthrocentesis or arthroscopy, that we routinely perform is a joint block. 1 ml of lignocaine injected directly inside the joint at the chair side. And what it does is, if the pain is coming from the joint, 100% pain is coming from the joint, 1 ml of lignocaine injected in the joint will reduce the pain completely, 100%. So that's the diagnostic test. We can explain to the patient that now, since the conservative treatment is not work, your muscles are normal, the muscles are not tender, the pain is specifically coming only from the joint, and arthrocentesis or arthroscopy will definitely help you. So post arthrocentesis or arthroscopy, you again continue with the same conservative treatment or physiotherapy. Now, when they move further, say intermediate, so patient has a frequent tenderness, headache, locking. This is anterior disc displacement without reduction, and they typically complain with the chew on the opposite side. That is the load. And this patient, they typically come with a history of macro trauma or maybe some micro trauma. So macro trauma in the term of that they will complain that I had some clicking sound 1 year back or 6 months back, and all of a sudden when I tried to open my mouth, now my jaw is stuck. That means the disc which was anterior disc, the joint which has anterior disc displacement with reduction has progressed to the anterior disc displacement without reduction, and it is stuck. Now this patient, if they turn off within the 2 months of that condition, those patients can definitely get managed just with the conservative treatment, how Dr. Chetan suggested. They give some sort of splint or maybe some physiotherapy, isometric exercise, jaw stretching exercise. But there are chances that they may progress or they may fall into your cord, and you may have to perform arthrocentesis or arthroscopy. So Wilks 2 and 4, they have a good response with the arthroscopy or arthrocentesis. And lastly, when they progress or when there is a complete shattered joint, say when you hear the crepitus, and you definitely know that this is osteoarthritis, this patient definitely requires some sort of open joint surgery. But before that, there are good that those patients transiently, not permanently, transiently respond to the conservative treatment and arthrocentesis, because you are actually debriding the entire joint, removing the inflammatory fluid, expanding the joint, releasing the pressure. So they do respond, but here we need to explain to the patient that your joint is completely shattered and you may require some sort of either joint replacement or open joint surgery in future. So it is like ACL tear, how they explain, orthopedic surgeon. When they do some arthroscopy or lavage procedure in the knee, they do not give a guarantee that your knee joint will not require a knee replacement in the future. The same thing happens with this synovial joint. Patient is using joint for, say 15, 20 or maybe 30, 40 years. So there is a evidence of wear and tear inside the joint. And when those joints come to you have to give a realistic approach. You explain to them that you will improve, but this is a transient phase, and you may have to go for further invasive procedure. So this is basically a small algorithm. I'll give you one broad idea at the last slide. So now arthroscopy, how do you define arthroscopy? Arthroscopy is a minimally invasive surgical procedure on the joint for examination or sometimes the treatment of the damaged tissue with small arthroscope or endoscope. So we all are, we are doing open joint surgery. So when you start doing any endoscopic procedure, we need to change our perception, because as a surgeon, we are used to seeing things from outside inside. When you open the joint, you see with your naked eye and you see inside the joint. So when you put a scope in your hand, you have to change the perception. So now you are seeing the joint from inside out. It is like you are standing inside the joint. It is like you are standing inside the joint and looking around the joint. It's like when you stand inside the room and look around, there are 4 walls. So same thing, you have to, 3-dimensional image of your joint, you have to visualize with your scope. So that requires little hand and eye coordination, and it is difficult to master, and sometimes it takes years to perfect that technique so that you can enter the joint with a single puncture without damaging the joint. So what does it do? First of all, it's same as arthrocentesis, level 1 or diagnostic scopy, lysis and lavage the upper joint. So what it does is it removes all the inflammatory fluid joint. Now what happens in the inflamed joint is, because of the inflammation, it releases the synovial fluid inside the joint. So joint actually collapse. When joint collapse, and because of the synovitis, there is a lack of lubrication system inside the joint, which is the synovial fluid. And when there is a lack of lubrication system, there is a more friction between the joint structure, and which leads to further damage of the joint. So with your simple lavage, it expands the joint. Once it's expand, and once you remove the inflammatory fluid, joints start to function normally. The idea here again is not to bring the disc in the normal endometric position. The idea is to bring the function of the joint normal. So when you expand, it reduces the inflammation inside the joint. And after that, when you give a physiotherapy, they start moving, the joints start moving. So in literature, and if you see the literature from 1975 to 2020, the success rate of the arthroscopy is mentioned as 85 to 96%, which is considerably very good in terms of joint surgery. Because if you see the literature on the orthopedic side also, their ACL repair success rate has been mentioned as a 80 to say 92%. So arthroscopy you can do as a 2 type, diagnostic or operative. Diagnostic arthroscopy, when it is same as a scopy guided arthrocentesis, where you lavage the joint entirely with say 300 or 500 ml of ringer lactate. And when you see something which requires some intervention, so you can put a second port and do either laser cauteric ablation or ultimately disc repositioning. So we'll just see few of the evidence which is mentioned in the literature. This is the largest study just published actually in 1992. It's a 6-center multi-center respiratory study of 4,831 joints, 6 years, 4,831 joints. There are, I mean, this was published by Professor Josephine McCain and Bruce Sanders. I think we know them very well because they are the pioneers in establishing the protocol for the arthroscopy in the world. So the mean age of the patient was 32.6. The patient range was 10 to 83%. The male to female ratio, as we all are aware, it's 1:9 because it's more common in female. And it was a 6 years retrospective study. So the arthroscopic, the diagnosis, initial diagnosis of the this all patient internal derangement with closed lock, that is anterior disc displacement without reduction, around 1,368 joints. Internal derangement with painful lock, again it's anterior without reduction, it's 780 joints. Osteoarthritis 556 joint, hypermobility 146 joint, fibrous ankylosis 106 joint, and simple arthralgia, that is arthralgia is painful joint without inflammation, around 103 joints. And they have quoted 91.6% as a good or excellent motion, that is the function, 91.3% is good or excellent pain reduction, and 90% of the patient, they maintain a normal diet. Now, when we talk about the function of the joint and when we explain to the patient, the normal diet means a normal diet. See, anything when you do on the joint, either you do some sort of conservative treatment, splint therapy, or maybe arthrocentesis, arthroscopy, or upon joint surgery. That doesn't mean that joint is going to function as normal as when they were around 10 or 15 years old. I mean, it's a dynamic structure. You are opening the joint, you are doing something. You can bring the joint to the normal function. The normal function of the joint is 35 to 40 millimeter of mouth opening, painless movement of the joint, and painless normal diet. Painless means if they try to eat, say, almond, or maybe if they try to eat large pani puri after doing some scopy, it is going to do, I mean, the same thing is what you have to explain to the patient realistically. When you do something on your joint, do not expect that you will start breaking an almond with your jaw. Your joint may function normal, but when you do eccentric movement, it may cause the same problem again, and you may damage your joint further. This is another study. It's a very nice study. There are two groups actually. One was Kyoto groups and one is Vienna group. The Kyoto group was performed by Dr. Murakami. So what they did is they compared the results of the open joint and open joint surgery and the arthroscopic surgery over a period of 5 to 6 years. So for the open joint surgery, Professor Gerhard Un from Vienna, he did 28 patients, 26 female, 2 male, and on the Kyoto group, that is Professor Murakami, he did around 29 patients, 27 patients female, 2 male. He did arthroscopy on Wilks 3 and 4 patients. Wilks 1 and 2 and Wilks 5 patients were excluded from the study, and they compared the result over a period of, the follow-up period, the mean follow-up was around 4 years. So what they concluded that open joint surgery gives the same functional result in terms of movement and in terms of pain reduction. But since arthroscopic surgery is a minimally invasive procedure, resulting in a shorter or no time of hospitalization when compared with open joint surgery, it is recommended that you perform minimally invasive surgery, either arthroscopy or arthrocentesis, before you jump to directly to open joint surgery. There's another study by Andrew Sidebottom. They compared the accuracy of the arthroscopy in diagnosing the joint and classifying according to Wilks classification. So what they concluded is arthroscopy has 87% sensitivity and 99% specificity in diagnosing the disease in the TMJ in terms of to allocating those joint according to Wilks classification. It has a sensitivity of 94% and specificity of 98%. Now see, these are the long study, long long study and articles or literatures which says the minimally invasive surgery has a definite role, but it does not mean that that's the final treatment for any TMJ. It's a combined treatment modality. So there is a role of conservative treatment, there is a role of minimally invasive procedure, there is a role of open joint surgery. And when you in that way, they will, they will benefit more over a period of years. I think we have two cases to discuss, which I have almost now 6 years of follow-up over a period of 6 years. So those two patients will be interesting to discuss. So now arthroscopy is basically divided in two parts, level 1, 2, and 3. So level 1 is basically a diagnostic scopy where you just put the scope inside the joint, you see the joint, you take a photograph, you identify any problem, you lavage the joint, you come out. So I say if you are doing 100 arthroscopy, if you, so first of all, we need to understand that TMD, if you see 100 TMD patient, only 15%, that is the 15 out of 100 patients are going for either open joint or minimally invasive procedure. And those 15 out in 15% also, say if you are doing 100 arthroscopy, only and only 10% of the patient will require some sort of level 2 or level 3 arthroscopy. The majority of the patient can get cured just with the level 1 arthroscopy. That means the arthrocentesis has the same role. I mean, level 1 arthroscopy is arthrocentesis, except for you are seeing the joint visually, so that when you have some doubt or when you see something abnormal, you can go therapy. So this is level 1 arthroscopy or diagnostic scopy. The level 2 and level 3 is basically therapeutic arthroscopy. This is a slide which is actually borrowed from my good friend and my teacher Gary Warburton. So level 1 scopy. Now, what are the instruments you require for level 1 scopy? There are two scope available in market in India. Right now, one is Rhodes system or Hopkins arthroscope, and second all-in-one fiber optic arthroscope. Now, I'll just brief you what is the difference. I usually use this Rhodes system. So it has a 1.9 mm Rhodes system. Then there's a sharp trocar with the marking. This trocar is usually used to gain access to the joint. This is for the irrigation. So the scope is 1.9 mm, but this trocar is 2.3 mm. So when we put the scope inside the joint, there is a space around this scope, say around 0.1 ml. So this irrigation system, it goes inside the joint and it lavages the joint. And there's a light source adapter where you can adapt other light, and this goes to camera. Now, system which is available right now, one is 0 degree and one is 30 degree. Now, I prefer to use, when you start the arthroscopy, start with the 30 degree because 0 degree has a very limited use in arthroscopy. It is easier to learn on 0 degree. Learn, then you realize that 30 degree has a more value in terms of diagnosing and therapeutic. So what is 0 degree is when the scope, as there is directly you can see in front of the wall. So say I'm inside the joint, I'm seeing the medial synovial wall. And if I want to see a glenoid fossa, I have to move my hand down and see upward. Same way when I want to see my retrodiscal ligament, I have to move my hand up and see down. So you have a lot of hand movement to see the joint space. But since the joint is very small, 0 degree is difficult to maneuver. So the 30 degree has a slight slant. So you can see in the front as well as slightly above. So say when you want to see the glenoid fossa, just rotate your scope. When you want to see the anteriorly, just rotate the scope. And when you want to see on the retrodiscal, just rotate the scope instead of moving your hand. This is a fiber optic scope where everything is in the single system. It's a very fine, it's 1.3 mm fiber optic scope. So you don't require actually the main advantage of this scope is you don't require, if you are doing arthrosynthesis routinely, this is the easiest thing to put inside. I mean, it's a 1.3 mm, it is a smaller than even 18 gauge needle. You just put inside and they have irrigation channel as well as an output channel. So you irrigate from this channel, the ring collector will come from this. And they have a few instruments which you can use from this port to do either biopsy or maybe some sort of maneuver inside the joint. So road system, basically, it's very durable. I mean, you can autoclave that scope. I'm using the road systems is almost now 10 years. It's very rigid. The resolution is high, and you get a wide field of angle. I mean, wide field of view. So when you are inside the joint, you have a limited mobility. So you want to see joint sitting at the one place entirely. It is like when you are inside the room, if you sit at the door, you can see entire room. So when you sit at inside the joint near the capsule, you want to see entire joint. So road system helps there. The disadvantage is it has a very steep learning curve. As I said earlier, the entering the joint, you require hand and eye coordination. Get a single shot to enter the joint, because if you cannot enter the joint with a single, you actually end up puncturing the capsule. And once you puncture the capsule, you cannot insufflate it. If you cannot insufflate, you cannot again puncture the joint. So diameter it is more. It's 1.9 mm. So I mean, for to learn this to inside, I mean to go inside, the chances of damage to the structure is more. It is very technical and it requires two puncher. So I'll show you. It requires two puncher. One is to see inside this joint, and one is for the irrigation. So all in one, and this system you can use only under general anesthesia. I mean, you cannot put road system scope under local anesthesia, because then it becomes very painful. All in one fiber optic scope, it has an advantage of, it is a, you can just do in a single puncture. I mean, you don't require to put a second puncture there. It is easy to learn. As I said, if you are doing arthosynthesis, you can directly put the scope and see. It is very smaller, and you can use this as an office-based arthroscopy. I mean, you can do under sedation or local anesthesia. The disadvantage is it is a fiber optic, which is very delicate. If you handle it properly, you may end up breaking that very fine instrument. The field of view is small, and it is available only in the 0 degree. It is only available in a 0 degree. So, I mean, if you just want to do a lysis and lavage and see the scope, I think all-in-one scope is a good option. But when you enter in the arthroscopy, you may proceed forward, say down the line 5 to 6 years. So it is better to invest in a system which is more rigid. So, and there are two types of camera. Chip camera, you can see here is the resolution is less small size, and this is a 3-chip camera. You see crisp, even small capillary you can see very clearly in the 3-chip camera. These are a few of the instrument which is available right now. This is a sickle knife. You can cut the fibrous adhesion. This is a palpation hook. Palpation hook is basically your hand inside the joint, because you can palpate things inside the joint. The consistency of the retrodiscal ligament, consistency of the disc, consistency of the fibrocartilage in the fossa. Then you have this sharp and blunt trocar. Is alligator to take a cup biopsy of the synovium, or maybe when you do a level 3 arthroscopy to do a discopraxy. And there are micro scissors to cut the bands. And this is a electrocautery, and this is a coabulator unit. This I'll show you some of this use. You can use it for chronic dislocation cases to cause a scarification of the or capsular raphe of the posterior retrodiscal ligament or oblique protuberance, so that it causes a scar formation and reduce the dislocation. And this is a motorized unit. They developed this to do amynectomy, but nowadays it is not available because to control inside the joint is very difficult. Amynectomy is spared for the open joint procedure. And this is a typical OT setup. If you see here, you need a 2 assistant. One assistant will continuously hold the jaw forward. You have to dislocate the jaw until you dislocate the jaw. And this is true for arthosynthesis also. Even you are doing under local anesthesia, ask the patient to open the mouth as much as possible, because the more the joint is open, there are more chances that you may hit the posterior retrodiscal tissue and go inside. And the second assistant is continuously irrigating the joint with ringer lactate. So I use this system. three ways. Goes inside the finger elected, and second goes inside the joint, so that you can control actually the pressure what we are giving to irrigate. Now, if you are ever seen the endoscopic surgery, it is mandatory that there should be a continuous flow of the fluid to visualize, because if it stops, joint collapse and you cannot visualize. So that's the reason. So this is the system I use, and sometimes when we do a scopy, it goes up to 1000 ml. I mean, the 1000 ml of finger elected without actually causing any bulge on the preauricular region. So this is actually developed by Professor McCain. The level 1 arthroscopy is a single puncture outflow diagnostic sweep. You can deposit some sort of medication like direct injection of the steroid, or maybe if you want to inject specifically in the oblique protuberance or retrodiscal ligament, Satrol or sodium tetrahedral sclerosing agent basically, or say in dislocation cases, you want to inject the blood, if you want to see that if you are injecting that blood properly inside the joint or not. Then when you do an operative arthroscopy, you need a second puncture. You put a second trocar to insert a probe alligator or cobbletter. And level 3 is multi-puncture arthroscopy, where you put a third trocar to take out the suture from the. This is a level 1 arthroscopy. The indication are, I mean, any patient of Wilks 2 and 3. In summary, any patient of Wilks 2 and 3 who are not improving just with the conservative treatment for 8 weeks. I usually wait for 8 weeks for any patient to take a call and take a patient for arthroscopy. To confirmation of a diagnosis, to take a biopsy. So recently I actually heard Professor McCain, he says that everything lies in the synovium. So when you take a synovial biopsy, you will actually know what pathology is going. I'll be showing one cases for discussion which actually requires some sort of histopathology. Then Wilkes 2 to 5. Now 5, as I said, you are just giving them a intermittent treatment where they will improve, and that may go for years actually. But ultimately they may require some sort of surgical intervention or open joint surgery or joint replacement. Then primary arthritis. The contraindication is only, this is indication internal derangement, hypomobility, synovitis, immune synovitis, invasive joint disease, hypermobility. And contraindication are ankylosis. You cannot, advanced bony ankylosis, of course, you have to do open joint surgery. Comorbid medical condition, that is for with any surgery, the patient is contraindicated for general anesthesia or too old, then emotional instability. This is where you have to be careful. This is what I was talking. You have to scrutinize your patient. You cannot put scope each and every patient who walks to your clinic. You have to scrutinize that. Do those 3 tests. If you feel that this is my patient, wait for 8 weeks. If they do not improve, take MRI, and then you enter the joint. And of course, local factor like skin infection, or when you are suspecting some tumor, you should not enter the joint because there are chances that you may do a tumor shedding. So which was published by Professor Joseph McCain in 1988, that arthroscopy of the human temporomandibular joint, and after that he started publishing n number of articles on the same. So the method he mentioned in 1988 is still stand the same. It is like a chain. There are multiple couplings which are attached together, and if you break one, you may go wrong. So it is like a circle of a chain, and I call it the muscle memory. You have to develop this muscle memory. So every time you take a patient inside the operation theater, you follow the same step. Palpation under general anesthesia, marking, local anesthetic insufflation, trocar entry, backward scope, outflow, diagnostic sweep, injection of medication, and ultimately manipulation. So this is a chain. This is an entire chain. If you take out anything from there, you may go wrong, or you may end up in some problem. So this is like a muscle memory. Over a period of years, you develop a muscle memory. So it happens by default. When you take patient inside the GA, it happens by default. So there are three fossa entry: fossa portal, intraeminence portal, and transmeatal. Usually use these two. Transmeatal actually mentioned by Jeff Moss. He used very. It's actually very difficult to do that. Professor Chang from China also it does very efficiently with this, and you need a real good hand to develop a skill for transmeatal portal. So I usually prefer to do fossa portal and eminence portal. And again, is another landmark article which he published in 1991 where he mentioned all the steps and the puncture technique. So this is a very simple puncture technique. This you can use for even arthrocentesis. So now most of the literature, what they've mentioned is you use a Holmlund Hensel line which connects from the tragus to mid of the tragus to the cantha and go 10, 7, 20, 10 to 27, where your 10 is basically 10, 7 is basically your inflow needle, 22 is basically your outflow. So, but what he has mentioned is very simple method. What he has done is so you palpate. You palpate the fossa and put a small mark at the highest point of the glenoid fossa. This is the glenoid fossa, this is the highest point. You put a simple mark and that's your entry point for your the trocar entry. This is just for demonstration. I have put a Holmlund Hensel line where you draw a line connecting the canthotragal and tragus, and from canthus and tragus you go 10 millimeter forward, 20 millimeter, and 10 to 27. Now, how does that help actually? So this is basically a general idea. So 10 to correspond to the highest point of the glenoid fossa, and 27 correspond to the eminence. So this is just a generalized. So if you palpate this with your finger and put a mark, you will never go wrong, because sometimes because of a difference in anatomy, you may go wrong here. So you just palpate the highest point on the glenoid fossa with the finger, put on mark. Now from when you put a mark, now the idea is why it is 10, 2, and 27 is because of this slope. Because of this slope. So it is not necessary that you go 10, 27. From here, say you go 5 here and come down 5. So you will be in the fossa. From here, you go say 6, you come down 6. This is because of the, so you go on the line, the millimeter, you come down same. And ultimately you will be inside the fossa. So this is a general idea. So first you do is mark the point, then examine under the general anesthesia. I mean, you wear a glove, open and close, palpate, see if there is a displacement, if there is a movement. You take a stethoscope, put a stethoscope on the joint, try to identify the noise, either it is a clicking, crepitus. So you, before doing that, you understand what you are expecting. If there are crepitus, you know there is a perforation. If there is a clicking or popping, you know that there is disc is stuck even after general anesthesia. That means there is a mechanical obstruction. It is not because of the muscle, because you have given the muscle relaxant. Then this is a most important step actually, insufflation. Now, what is insufflation is, now see, joint is basically, sorry. See, joint is basically the upper compartment of the joint is around point, I mean, the entire joint is say around 3 to ml. The upper compartment is 0.9 to 1.5 to 2 ml. Lower compartment is another 1 ml. Now, if you try to go directly in this space, which is on the posterior part, say this is 0.6 ml, the chances of you being inside this area is less, because it is collapsed. Right now it is covered by this retrodiscal ligament, then your bony mark. So what you have to do is you have to insufflate. That means you have to make a balloon. You have to expand the joint. So what you do is from the tragus, with your thumb on the highest point on the glenoid fossa, you direct your needle to the posterior slope of the eminence. That is here. This is a posterior slope of the eminence. You direct it. So when you hit that, you withdraw it and then inject 2.5 ml of plain lignocaine with saline. Initially I started using bupivacaine, but refrain of using bupivacaine because the huge article saying bupivacaine or the sensor cane is a highly chondrotoxic. I mean, it is highly chondrotoxic. So 1 ml of plain lignocaine mixed with the saline, you go there, inject. So now what is happening? You have injected 2.5 ml of fluid inside this joint and you have made it balloon. So you will have a more here. Now say you are doing arthrocentesis. When you are doing arthrocentesis, you don't have to remove this needle. You keep it there. You keep it there, and while injecting, while you're making this entire joint balloon, you insert the second needle. It is always easier to puncture that balloon joint than the collapsed joint. So what happens is when you try to say you have injected and you are trying to put it inside, then you may actually cause a insufflation in this area. So this is very important. So insufflate properly. This is the trocar entry. It is very simple. You enter with the trocar, and this is a backwash. So once you have washed this joint, you can now insert this is a scope, and once you insert the scope, now this is a hazy look. That is because there is no outflow. This is a hazy look because there is no outflow. So then you put a second needle. See the myastic joint. It is easier. Once it is very easier to put the second needle. So now you are inside the joint. So you know do the diagnostic sweep. In diagnostic sweep, you identify all these 7 structures. Is a medial sinus drape, retrodiscal tissue, your glenoid fossa, articular eminence, your posterior slope of the disc, and anterior recess. So there are 7 structures you need to identify, and this is a diagnostic sweep. I'll just show you another patient. So this is the patient actually of level 1 scopy. There's a restricted mouth opening. You can see here there is a disc which is stuck anteriorly, and there is a restricted lateral movement on the right side. So this is almost after 2 years of follow-up. You can see the mouth opening. There's no restriction. Here we have not tried to bring the disc in the normal position. As Dr. Chetan suggested, after conservative treatment and after arthroscopy, that posterior retrodiscal tissue is fibrosed, and now it is acting as a pseudo joint. So idea is not to bring the disc in the normal position. Idea is to establish the normal function. I'll just finish fast. This is another article which is published by Professor McCain, where he said that you need to do some sort of surgical procedure in when the primary arthroscopy does not work. Say Wilks 2, 3, and 4 arthroscopic discectomy, or discopraxy. Then 4, you can do debridement. 5, arthroscopic debridement. Osteoarthrosis, again you just need to do debridement because the disc is already shattered. You cannot do anything with the disc. Then hypermobility, you can do a scar contracture. I'll just show you that. And you can do a synovectomy or maybe installation of the medication. So you need to put the second trocar. There is a technique to put a second trocar. Here you can see one fibers which is lying in the anterior recess. Now when you want to cut that, you have to put a trocar which is actually going anterior. You mark it, you go directly inside the joint, This is, I'm direct visualizing the needle inside. And once I'm sure that this is my area of entry, I'll just put the trocar. You can see here the trocar coming inside. You have to be very gentle because this sharp end can actually damage any of this structure. You have to be very gentle here. And then now in this trocar, you can put any of the instrument you like and do this is why I'm putting a scissor here and just chop off that fibers from this. This is a steroid deposition. Again, I'll show you directly. This is a highly inflamed joint. You can see from inside. It's a highly inflamed joint. We'll discuss this case during the discussion. This is a disc actually. This is a glenoid arterial remnants. And that's the anterior recess. You can see there is a lot of inflammation in the anterior recess with tear in the muscle. This is a tear in the muscle which was causing a problem. So with the direct visualization, you can inject any medication like we tried to inject the steroid. You can see here the steroid, which is same way you can anything. And this is another electrothermal capsulography for the dislocation. Here, the Professor McCain mentioned the technique where you can actually do a scarification of the retrodiscal ligament. He published the patient, 11 patient study with a 2 years follow-up. So this is the patient you can see now. This is called an open lock, painful open lock, where she will open and then it will stuck. So when you take an MRI, the condyle is itself is a anterior to the articular eminence, but the disc also is still anterior to the condyle. This is called open lock, painful open lock. You can just take your electrocautery. You can do a scarification of the posterior retrodiscal ligament so that it causes a contracture and it is same as injecting your sodium tetradecyl sulfate or sclerosing agent in the retrodiscal ligament. This is my bipolar actually, which I am using. You have to be very careful when using bipolar because it can heat up the joint very fast. When we use that, we prefer to use a chilled normal saline solution. So this is scarification. And this is a disc manipulation. You can use the disc. These are all level 2 procedures. This is my probe. And this is the last. Few of the patients who do not improve, say in the open lock or closed lock procedure, and when you see that this, and in there is a evidence in on MRI the disc is intact. When this structure is changed, say buccal, there is edematous disc, there is no point in getting the disc back in the position. But say the disc is intact, there is enough space between the condyle and the glenoid fossa on the MRI that it can hold the reduced disc in the position. And when there is open lock, you can perform this procedure. This is like the right side. She had undergone once arthrocentesis by me, but then she did not improve. So this is the second trocar we are putting inside, and that the disc is reduced. You can see this video on actually YouTube, my channel. Entire video is there. So the disc is reduced, held in a position by my, yeah, so you can see the pop. You can see the pop. So now the disc is held in the position. So now white on white, that means the glenoid fossa and the articular disc. The disc is held in position. So now from the below, you have to put a suture there. So see, the disc is, patient has a closed mouth, disc is held in a position. Now you can actually walk on the condyle, go from underneath. This is a spinal needle. I'm trying to go from inside. The assistant is holding disc in a position. I'm visualizing the disc. This is a third spot to take out the suture. And you can see the needle, which is going from below the condyle or the inferior space, coming above, that is in the superior space. So now when we have this needle inside the joint, you can pass a 2O PDS through that. So that will go from inside or the below the joint. Yeah, so 2O PDS is going. So it is going from underside of the disc coming out above. This is highly technique sensitive procedure. And now you can take out this PDS from this trocar, which is lying above or in the superior space. So this is my grasper going in, taking out the suture. You can visualize here that suture is coming and the second thread has come out. So now this trocar will come out, this needle will come out. Still my assistant is holding the disc in the position with this. So now there are two threads. You can pass, you can just put a small stab incision, dissect till the capsule and take a needle and take a stitch here. Now disc is held in the position. When we do this, I usually ask patient to refrain from any physiotherapy because the idea of this is to cause a fibrosis of the retrodiscal ligament so that it can hold the disc in position. So for at least 21 days, we don't allow patient to do any physiotherapy. Thank you.
Thank you so much, Dr. Nehal. That was definitely a wonderful presentation. And I hope because of time, there was some, you had to go a little fast.
That is fine.
but we will be able to listen you only for arthroscopy sometime for a longer period of time. But as usual, it is fantastic, Nehal. And we look forward to our question and answers and your case presentation.
Yeah.
So next will be Colonel Saxena, Colonel Vivek Saxena. He is heading the Department of Oral Maxillofacial Surgery at R&R Hospital in Delhi. So he will be talking on open joint surgeries as we have reached from conservative to minimally invasive and then now to open.
Am I audible?
Yes, sir.
Yeah, just let me just go to the screen. Am I visible also? Hello.
Yes, sir. Go ahead, Pilli. Go ahead, sir.
Yeah.
Go ahead.
So a very good evening to everybody. I think in this topic which has been given to me by Dr. Ashish as the moderator, I would say this is one of the most difficult topics. The reason being that in 2020, when we are talking about joint surgeries, in terms of TMD, open joint surgeries, especially in TMD, is like talking about conservative management in maxillofacial trauma. The reason being that the joint has remained an enigma for a long duration of years. It would be surprising to know that the most common musculoskeletal problem after backache. So we are looking at something which is very much prevalent in almost the global 5 to 10% of the population. And I would put it as it is a yet to be understood anatomical region. The reason being it's an intriguing physiological dynamics. We may not even see that the patients who are being given the same type of treatment may not respond to those treatments.
Time की थोड़ी ना 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 यार वो उधर से बोली और ये लोग जो है ना मैसेज कर देते हैं.
And also we should know that the patients who are coming to us with TMDs either in their initial or advanced stages, they would definitely not have a stock treatment available. That is the biggest concern as we manage the TMDs, that there is no stock treatment available. It has to be customized as per the patient's requirements. And it is also to be seen as to how the patient is progressing on the positive or the negative side, as and when we are doing a conservative management. Now, when we look at the figures, it is very surprising that 90% of TMDs respond to non-surgical treatment. So it makes it all the more interesting for us maxillofacial surgeons talking about a non-surgical treatment when our bread and butter is surgery and the knife. So when we look at the figures, it is 5 to 10% who will ultimately need surgical intervention. Either they will be failed conservative management, or they will be largely due to the poor diagnosis from the earlier clinicians. Now, what is the consensus? There's a plethora of literature available on all these topics, right? Starting from the conservative management, the arthrocentesis, the disc plication, the splint therapy, the pharmacotherapy. But still in 2020, we don't have a consensus on what we should be doing in a particular case. There is some clarity as far as the joint replacement is concerned, in a very remarkable article by Dr. Andrew Sidebottom, which I shall be sharing in the process of my presentation. But largely, there's no consensus. And when we look at the algorithm, that is, even in the most advanced disc dislocation without reduction situation, the conservative management of arthrocentesis and arthroscopy has a definite role. So that goes without saying that even when we are looking at a condition of disc displacement without reduction, surgery still remains the last option. So with that backdrop, now what is the rationale for surgery? We all are aware of the Wilkes classification, that is the staging of the internal derangement. Now, Wilkes has divided into 5 stages. This is a 1989 otolaryngology head and neck surgery article, wherein you have 5 stages: the early reducing, late reducing, and non-reducing, which may be acute or subacute. And then is the chronic non-reducing disc displacement, and then stage 4 with osteoarthrosis. Now, what happens here is that in Wilkes system, there is no treatment modality which has been advised vis-a-vis the staging system. So Dimitrolis in 2013 further modified it, and it's a very comprehensive work by Dimitrolis, wherein he has divided them into 5 categories. The categories are, wherein the first category is normal, therein the entire jaw is normal and it will respond to conservative management, and there are no surgical interventions indicated. Then further he goes on from the level of severity of minor, moderate to severe and catastrophic. Now in minor, he says that even if there's a closed lock, the arthroscopic lavage may be helpful, and the joint has all the salvageable components, that is the disc fossa complex, the condylar head. Then as it progresses down to the much severe variety, finally we reach to a place which is TMJ catastrophic changes, where nothing is salvageable. So these are the cases where total joint replacement in terms of TMJ is indicated. But apart from that, we just need to do an open joint surgery just to salvage the missing part or the damaged part. Now, who are the candidates for surgery? Here and again, 2011 Australian Dental Journal article by Dimitrolis underlines the fact that the absolute indications for TM joint surgery are largely the ones wherein there is involvement of the condyle. So we are looking at ankylosis, which may be fibrous or osseous. We are looking at neoplasia of the condyle. We are looking at the dislocation, that is where the condylar head is moving out from the realms of the glenoid fossa. And then you have the development disorders. So the absolute indications as lined out by Dimitrolis is related largely to the condyle. And when we look at the relative indications, we see that there is internal derangement as a relative indication. So this further depends our mystery regarding the open joint surgeries. Whether do we need to do an open joint surgery in case of internal derangement? And when we go down, we see in osteoarthrosis is given as a relative indication for TM joint surgery. The remaining ones we shall not be discussing for the paucity of the time. So who are the candidates? The candidates are largely when there's a bony pathology, when there's total flattening of the condylar head, very advanced stage, end stage TMD. Then you have the surgical requirement in cases when we look at disc displacement without reduction, because this is the condition wherein we have the limitation of the movement of the condylar head anteriorly to the glenoid fossa because the disc which is displaced anterior. Now this disc can be repositioned back either through the open joint surgery or through arthroscopy. Now as the conservative management, which is in a hierarchical manner, or a step ladder manner, wherein we go from the lesser magnitude of treatment to the final surgery, depending on the severity. So this is another cadaveric specimen depicting the disc lying totally anteriorly to the condylar head. And this is the MRI, which again shows the same thing. So this is a condition which is also known as closed lock, and there is severe limitation of the movement. So these are the conditions which, after the failure of the conservative management, including arthrocentesis, arthroscopy, are candidates for open joint surgeries. Now, what are the surgical options that we have? The surgical options can range from disc plication, discectomy, that is, disc plication is basically the tightening of the loosened disc and bringing it back to its position. Discectomy and then interpositioning it with some interpositioning material, which can be in the form of dermis, or it can be temporalis fascia, or it can be a dermis fat graft, or it can be auricular cartilage as well. Then you have the high condylar shave, also known as condylotomy. Then a relatively new modality in the form of mytic screw anchorage, wherein the screw is placed. I'll be sharing one of the cases done with this orthodontic screw anchorage. Then the condylectomy. This is meant for severe osteoarthrosis and end-stage TMDs. And finally, the pinnacle of the treatment modality as far as surgery is concerned, in the form of alloplastic joint replacement. Now, what we need to look inwards and introspect and analyze before we put down the knife is our diagnosis correct? Because most of the time we do come across patients wherein the clinician have gone in for a surgical intervention in the early phase of the TMD, wherein the conservative management would still be giving a good amount of results and outcome. Second consideration is, has the psychological component been considered? Because many a times it is considered to be a major aggravating factor, if not a major contributing factor in the TMD, which we see as a lifestyle disease these days. Then the third consideration is the occlusion not a factor? We do need to look at the occlusion as a factor, and we do need to take our prosthodontic colleagues on board, because they are the masters of occlusion, the orthodontic colleagues as well. That's why management of TMD makes it a multidisciplinary approach. Then, has targeted pharmacotherapy been done? This again remains a gray area, because till date we have not been able to unravel the mystery of which analgesic or NSAIDs or any other painkiller will give us predictable results in each and every case. That is the reason why TMD management, both conservative and surgical, remains an enigma till date. Is the splint therapy effective? Splint has been shown a lot of promise, but at the same time, the thickness, the softness, the upper or lower, the anterior positioning splint, has it been given to the patient and has it been effective? Has he complied with it? Will lavage benefit him? Because we have already seen the algorithm by Okeson mentions that even in cases of disc displacement without reduction, the lavage is one of the treatment options prior to putting down the knife. And last but not least, whatever surgery I'm going to carry out on this joint, will it be predictable? Because if it is not predictable, then being an irreversible procedure, there is no way that we can go back from surgery to conservative modes of management, while the vice versa is still possible. Now, the baseline imaging, though it has already been discussed, I would just rush through the imaging part. The baseline screening is by the OPG, which shows the bony bone quality, the contours of the bone, wherein the erosion of the joint is taking place in a two-dimensional. Then we go up in the form of a CT. This is a case of dislocation, wherein we can see the condylar head ahead of the articular eminence. Then the gold standard, the MRI. The MRI has been a boon as far as the diagnosis of the TMDs is concerned, because it shows the disc, especially in a dynamic MRI, lying anteriorly or posteriorly or perforated. Then we have the relatively new modality, of which Dr. Nehal has already discussed in much detail. The TM joint arthroscopy shows us in real time going inside the joint, and both diagnostic and therapeutic in its own way. So once we have done this imaging, the dilemma still continues, because even in 2018, there is still, the judgment is yet to be out on whether the non-surgical is effective or it is the surgery which should take the upper hand. So what it says is that in initial cases, the non-surgical modalities are better, and their efficacy and appliances, a definite conclusion still needs to be reached. So we are still looking at a gray area in TMDs. Then what further complicates it? There's again a landmark article by Dimitrolis on India, where he says only 5% of the patients require surgery. So we are looking at a large chunk of the TMD patients who will definitely benefit with conservative methods. So when do we do the surgery? Now I'll be sharing a few cases, representative cases of a few of the treatment modalities. Starting with this lady, there's a 58-year-old female who reported to us with pain right side preauricular region since 2 years. A gradually decreasing mouth opening was there, and there was a history of fallen chin during childhood. Most of the TMDs have at their base the etiology of trauma, which can be macro or micro in nature, and remaining aggravating factors can only be additional to it. So we diagnosed her with the imaging and the clinical examination as internal germinal will case stage 5, that is stage 4 plus osteoarthrosis. The further imaging showed us there is an anteriorly dislocated disc and there's good amount of osteoarthrosis on the right joint. Now, keeping in mind her age, the surgical magnitude was in the form of just a high condylar shave and the disc tightening procedure. These are the intraop images. The patient is on a 1-year follow-up and she has marked improvement in her pain and mouth opening. Now, when we look at the literature, when we search the literature, it says that discectomy as a primary option for internal derangement is a definitely positive reviews in all the systemic and meta-analysis. Also, it says that when the literature, we search for articles on the surgeries in which we carry out an additional procedure or adjuvant procedure along with disc plication, therein again, it says that better results are seen when we are doing a disc plication along with either an amerectomy or a condylotomy. So this definitely has a place in the surgical armamentarium when we are dealing with TMDs in the advanced stages. Now, the second case of ours is a serving soldier, wherein again in civil with he was already operated, and when he reported to us, there was already some surgical intervention carried out on his right condyle, but he still had a closed lock situation wherein restricted mouth opening was there, and whatever remnant of the disc was there, it was lying anteriorly to the condylar head. So we did a preauricular incision on him and took out a part of the condyle and the disc as well because it was badly damaged and perforated. And then we use a dermal fat graft, and it was used as an interpositioning material. Post-op, patient is on around 9 months of follow-up. His mouth opening has improved, the crepitus, the grating has reduced, and he is almost pain-free now. Now, when we compare the various grafts, there is a good article by George Dimitrolis on use of dummies graft. What it says is that one flip side of this is that it just eliminates the joint sounds. That is what the article says, that it just reduces the joint size or the crepitus, and it does not necessarily prevent the regressive remodeling of the mandibular condyles. So in a way, it is against the dummies graft. But when we again look at a critical review by the same author, wherein he has compared different kinds of interpositional graft, we find out that ultimately it's the dummies fat graft which has a better track record in terms of reasons that it has neo-adipogenesis capability. So this, when we compare to other grafts, either auricular cartilage, wherein there is a breakage, there is warping, or we look at the temporalis flap, the dummies fat graft holds a lot of promise, and it's easy to operate as well as easy to execute in the OT. Now coming to our third case, this again is a case done by one of my colleagues, wherein he has utilized the orthodontic screw. Again, this patient has an anteriorly dislocated disc with reduced mouth opening. An orthodontic screw has been used to anchorage the disc to it and getting it properly laid over the condylar head, which was anteriorly displaced. This is the video, intro video, which depicts the movement of the articular disc along with the condylar head once the screw has been placed and the disc has been tightened. The screw placement is, and this is the post-op mouth opening of the patient. He is again around 9 to 10 months post-op. He is pain-free and he is in touch with us. This is the technique which is used wherein we put it on the lateralmost, posteriormost aspect and then tighten the disc with the 2-0 or 3-0 polypropylene suture. Now this Mytec mini anchor is not a new modality as it is made out to be. It is already there in literature since 2001 and they have got encouraging results. The newer authors have also encouraged a smaller incision for same using the Mytec anchorage screw, and this is one of the techniques which holds a lot of promise for future. Now, why do we need to do a disc repositioning surgery? When we are doing a disc repositioning surgery, we must know that the disc per se is not perforated or damaged. If it is damaged, then the treatment modality changes, as we have seen in one of the cases. If the disc is just lying entirely and it's not perforated or damaged, then we just need to get it back in position because that is the more favorable and physiological method when we are getting it on the head of the condyle, and then it brings back to its normal position, is also effective in cases of long-standing internal derangement. And favorable outcome, as per a Korean article, has shown to hold promise in at least 80 to 94% of the patients. So this is one of the open joint surgeries which should be considered before going for more radical surgeries in TMJ. Now, when we look at the article by Roberto Gonzalez in 2014, he says there is evidence to support the assumption that TMJ articular disc repositioning indeed works because there is no evidence that it does not. So disc repositioning is a very delicate surgery which can be learned with not too much of a steep curve with just a preauricular incision, and it is advocated in terms of anterior disc displacement without reduction. Now, when we come to the pinnacle of TMD management surgically, we must remember that this is one procedure which is being hailed as the boon to the patients, but there has to be a word of caution as far as the application is concerned in maxillofacial surgery for TMDs. The reason being that the age profile of the patient. First, we'll just look at the indications as given by Dr. Andrews at bottom. He says the disease involving condylar bone loss. So this is very much in consonance with what Dimitrolis had to say when he talked about open joint surgeries in terms of his article, wherein they were largely, the absolute indications were largely reserved for the anomalies which were taking place in the condyle, that is the bony anomalies. And he is also in agreement because he says that degenerative joint disease, osteoarthrosis, that is where the flattening of the condylar head will take place, or ankylosing spondylitis translating into ankylosis in some patients, then post-traumatic condylar loss. So they are largely in the bone, wherein we need to replace and get the vertical ramal height along with painless joint movements. But this also has to be taken with a pinch of salt, because what happens here is that even though it is being advocated as a boon, we must realize that the age profile of the patients in TMD is much, much lesser than those requiring replacement of joints or other parts of the body. This has to be borne in the mind because as per the manufacturers of the only joint which is FDA acceptable, the Biomet Lawrence joint, now which has been taken over by Zimmer as well, is around 10 to 15 years. So if we are operating a patient of say around 30s or 40s or maybe 50s, then he has just a longevity of 10 to 15 years with the joint. And with the age expectancy, the life expectancy reaching the 70s, it would definitely has to be a call has to be taken before taking a joint replacement in the TM joint vis-a-vis the orthopedic joint replacements for the hip and the knee, because we are treating those patients at an age group of above 50 or 60. The TJR, the total hip replacement or the shoulder replacements are largely reserved for people in their past their prime. So this is a major consideration when we are doing a joint replacement for TMD. Now, this is a case of FAST done as a part of the maxillofacial team in AFMC, where in this case of ankylosing spondylitis developed ankylosis bilaterally. You can see the bony fusion on one side and almost fibrous on the left side. So we took him up for joint replacement using biomed Zimmer, wherein ultra molecular weight high polyethylene, the fossa component, and then the condylar fragment, which is a cobalt chromium sprayed by titanium. The intra-op occlusion and the intra-op opening 40 mm, though it is anticipated to be reduced because with the joint you will be able to get around 30 to 35 mm finally. This is the post-op imaging with the joint in situ, alloplastic joint in situ. Then there was a meta-analysis done on a different type of joint. We have the stock joint and the custom joint. Now the stock joint is coming in sizes, I think 40, 50 and 55, which are not applicable in ankylosis cases, especially in pediatric and teenagers, because the bone stock remaining after osteoarthrectomy is not there. But in adult ankylosis, they can still be used because we have a good amount of bony stump to use the condylar stump and the condylar component. So this is advocate for adults. And when a systemic review was seen, it shows that there are no relevant difference between the different TJR systems. Either they are stock or they are custom made. What is the road ahead? As we said, there is no targeted pharmacotherapy as far as the TMDs are concerned. There is no particular medication which you can say with confidence that is going to be effective in this TMD, the patient will have pain relief. So what we have for future is that we have biomarkers wherein you have the tumor necrosis factor R2 as well as TNF, which will be used for targeted pharmacotherapy development in future. Now, what is the take-home message? As I conclude this presentation on open joint surgeries, the accurate diagnosis holds the key to each and every outcome of surgery. No jumping to the surgical modality. Let all the conservative modalities be exhausted. Adequate conservative treatment over a period of time has to be instituted because surgery is an irreversible procedure. Apart from that, appropriate case selection has to be there. We cannot just go replacing joints with the alloplastic joint in the patient's age just about 30 because they have a high life expectancy. So you cannot expect in a country like ours for a patient to undergo multiple surgeries just for the purpose of mastication over a period of 30 years of his life expectancy, which is remaining after he undergoes the surgery. And first and foremost, and not the least, primum non nocere, that is first, do no harm. So whatever we do, the case selection has to be proper, exhaust all conservative treatment modalities. Arthroscopy has come in a big way, and Dr. Nehal is the pioneer in that. My acknowledgements are due to our DGDS, Lieutenant N.K. Sahu, Vishesh Seva Medal, who has been the guiding force and the leading light for the maxillofacial surgeons. He has been my teacher as well. And to my commandant, Brigadier B. Jain, Commandant Army Dental Center R&R Delhi, who has been very instrumental and has a major thrust area in research and further upgradation of the systems. To my seniors and colleagues who are involved in the surgeries that I have shared here, and to my residents with whom I learn and learn on a daily basis. Thank you very much.
Thank you, Vivek sir. It was wonderful presentation and absolutely to the point as all the presentations are today. And I think all the audience will be having a good time. And they must have got quite a bit of internal derangement and dysfunctions with all four of you. So now I would request Dr. Vishal Bansal, Dr. Chetan Hegde, Dr. Nehal, and Dr. Vivek sir, kindly you switch on your videos, all of you, all four of you. And Nehal, Dr. Nehal.
Yeah.
I would like you to just summarize all the things what we have learned in a few minutes for our audience, please.
Sure. This is my small last slide, and I think Dr. Vivek also mentioned it. So this is the actual protocol I have been following in my practice. That
Share screen, share screen.
yeah, 1 minute.
Mhm. Vivek sir, have you stopped sharing?
No, no. Acha, you
Yes.
want me to share? Acha.
Yeah, yeah. You stop sharing, sir. Then Nihal can share.
Okay, okay. Yeah. Done.
Yeah, so it's a small protocol actually. It's a very nice article, evidence-based. It's internal derailment of temporal joint, a new perspective on all problem by Howard Israel. So it's a more or less it's the same protocol I've been following in my practice, and I think most of you, from starting from Dr. Vishal to Hegde, me and Vivek sir has emphasized on the same thing, that do not jump on any conclusive or surgical method which is irreversible. You start with the least invasive method, that is a conservative treatment in the form of uh, splint therapy, physiotherapy, medication. So most of them, they respond well at that stage. If they do not, then you go ahead and do some sort of non-invasive method where arthrocentesis or arthroscopy can work. And if that doesn't help, then only you can. So ultimately, when if you see your open joint surgery comes down to around, say, 1 to 2% of the all the surgical procedure we do, and arthroscopy comes to around 10 to 15%. So this is a small protocol. So it's anterior disc displacement with reduction clicking, but no pain. So this patient do not require actual any surgical intervention. Either there is a history of microtrauma, microtrauma. So you give education, you identify the etiology, and try to reduce the joint overload. That may be either in the form of clenching bruxism, or patient may have open widely stretched the retrodiscal ligament, and patient is doing those movements regularly after even stretching the retrodiscal ligament. So to educate the patient, you ask them to restrict the movement. You start with the hot fomentation. In case of chronic problem, if there is acute inflammation, I suggest start with the icing, some anti-inflammatory, either pyroxicam or indomethacin, which works good in case of synovitis. Then if it is activities displacement with reduction and pain, same thing, you go 8 weeks of physiotherapy education, you reduce load, conservative regime in the form of medication and physiotherapy. If it doesn't work, do our MRI, identify the problem, continue conservative therapy, and then you go ahead and do either arthrosynthesis or arthroscopy. Anterior disc displacement without reduction, pain, no clicking, limited opening. Again, same regime in the beginning, 8 weeks of conservative regime. If that doesn't work, and then you go ahead and do uh, arthroscopy or arthrosynthesis. And in case of shattered joint or completely destroyed joint, uh, still there are chances that their joint may get adapted if patient restrict the movement. If they reduce the movement, and patient may become pain free with a normal function, not eccentric function. So educate those patients to conservative treatment, CT to evaluate the bony changes, MRI to see the soft tissue changes. Then do arthroscopy. That is not therapeutic, it's just a diagnostic. You do lavaging, you do debridement, you explain to the patient that there is an interim procedure. You may require some sort of open joint surgery if you continue to give the same uh, eccentric movement to your joint. And if it doesn't work, and then you can go in and do arthrotomy, or maybe disc procedure or discectomy. So this is a simple protocol which you can follow. This is basically for internal derangement. And as I said, we have to identify our patient. We cannot treat all the patient which enters to our clinic. We have to scrutinize them. If they are extra articular, we have to focus on an intra-articular problem rather than focusing on an extra-articular problem, which is a broad spectrum and which we I mean, it's out of our scope to treat those patients. I mean, there are psychological problem, mental instability, there are muscular problem, there are generalized problem. And if you start seeing and treating all this patient, you may get fatigue over a period of time. So this is a take of aim. You identify your patient, start with the conservative treatment, and explain to the patient. Communication is the best way to explain, and then step by step, you give proper treatment to the patient. And I feel if you follow this protocol, you may, I mean, you will have a success rate of say around 90-95% of the patient in treating the internal bleeding. Thank you. Thank you, Ashish.
Thank you, Nehal. Wonderfully explained. I think most of the questions are answered already. I would like to.
So what I will suggest is the case discussion. They have a lot of similar question which people have asked. We will just discuss one case.
Yeah.
One case we can discuss. Yeah.
Only one case, because all those questions which has been asked are going to discuss again in the same case discussion.
Sure.
So we'll just start with the case discussion.
Just a second. I would like to thank Dr. Dhiren Srivastav, Dr. Pravesh Mehra, Dr. Praveen Lone from Jammu, Dr. Ramkrishna Shenoy. It is wonderful to have you all people around, and it is really a moral booster for us, and we would like to continue with the same work in future as well. Over to you, Nehal, for the case discussion. And if still there is some question left, we will talk.
Yeah, no problem.
Thank you.
So we'll just discuss this one case. I am following this patient since almost now say 6 years, and every element what we discussed, starting from diagnosis to conservative treatment to arthroscopy to, can you see the screen now?
Yes.
Arthroscopy to open joint surgery is covered here. So this is a 42 years old female. She had a complaint of pain in bilateral periodical region when she came in 2017, 5 years back. That was in 2012. So on a VAS scale, the pain was 8. So that is a severe pain. I mean, she was not able to chew even simple roti. Mouth opening was surprisingly 47 millimeter, which is considered the normal mouth opening. I mean, so if you start looking at the patient with the history, now what it is happening is when she opens the mouth very widely, then she has a pain, and same as the chewing. So you can think that retrodiscal ligament is actually inflamed, or there is some sort of inflammation inside the joint. And there is no history of clenching out of bruxism. Patient had a good functional occlusion without any missing teeth or wear due to parafunctional habit. I mean, there was no clenching habit, no bruxism, very healthy female. She had a history of bilateral thermal removal 5 years back, and that was traumatic. As she mentioned that she had to keep her mouth open for almost 1.5 hours. And after that, it started the clicking, which progressed to this pain. The both side lateral extrusion of was restricted, and the pain in left joint while moving the mandible on the right side. That was, I mentioned, this is like the load test. So this is a contralateral side patient has a pain. Pain on the right joint while moving the mandible on the left side. She had occasional clicking. So load test, that is called the Mahan test, which I mentioned. You put a stick on the premolar, and if patient has a pain on the contralateral joint, there is an element of inflammation inside the joint. So this is a joint problem. Since it was a chronic problem, and so this is like a musculoskeletal system. One system is not working properly, the other muscles start compensating for that problem. So 5 years down the line, when she did not have a pain relief or functional improvement, her temporalis muscle, muscle, middle pterygoid muscle started compensating. They have a little bit of tenderness. And her all serology report, RH factor, HLB27, uric acid, everything was negative. I mean, she was not a case of primary arthritis. And when she came to me, we started with say simple regime for 8 weeks. She was already wearing a splint, which was actually a good splint. So I said, you continue with the splint, then he started some physiotherapy for 8 weeks, but that did not improve her function. And on the auscultation with the stethoscope, there was a clicking sound on the opening of the joint. So this is a basic history. Now, if you see her left joint close omeri, the joint is absolutely normal. I mean, there is no problem in joint except for there is a slight anterior placement of the disc, and when she is opening, the joint is going forward than the eminence. So with this, you can, think that there is a chronic elongation of the retrodiscal ligament. There is no actual displacement without reductions. You can say there is a displacement with reduction case. Very simple, same way, right joint, open MRI, the disc is sitting on the condyle head, the periphery of the condyle is normal, the fossa is normal, eminence is normal, disc shape is normal. The only problem is on the closed mouth, the disc is slightly anterior to the fossa and mild. I don't consider this as a very evident, but it's a mild fattening of the right side of the condyle with little bit of edema in the lateral pterygoid muscle. There's a bit of edema that is maybe because of the chronic problem. I don't have this long case, but I don't have the other cuts, but she did not have any bony problem. Did not have any bony component which was involved. So right joint, there was very mild effusion on T2 weighted image, which you can say it's a more of a chronic problem with edema on the lateral pterygoid muscle, and disc remain little anterior in a closed mouth position. So you can say it's a Wilks 2 basically. An open mouth position, it comes from the normal position, and eminence. It goes to left joint, absolutely normal architecture of the disc, very mild cortical. That it is. I don't say it is a cortical erosion, but maybe it is flattening because of the chronic problem. On superior surface of condyle, disc remain anterior to the closed mouth position, anterior disc displacement again, and open mouth position, mandibular condyle goes anterior to the eminence. There is no significant anomaly except if you compare from the left joint, there's a reduction in the space on the right side. You can actually, because otherwise there is no bony erosion or anything. So on base of this, my final diagnosis was a bilateral anterior disc displacement with reduction and subluxation, discal subluxation. So that is because the condyle was going anterior to the eminence and with lateral pterygoid edema on the right joint and synovitis. So this is a treatment given for 6 weeks, indomethacin, piroxicam, occlusal stabilization spleen for 8 weeks. But it did not work. I decided to go ahead and do a level 1 arthroscopy to see what's going on. And this is the scopy. If you see, there was a highly inflamed joint actually on the left side. You can see it's a completely red joint. Even after so much of the treatment, it was there's a attachment of the lateral pterygoid muscle on the anteromedial part. There is a mild, this is like a 10 times magnification. So I don't say there is a chondromalacia, but you can see the disc is moving properly on the top of the condyle. There's a creeping synovitis. Again, so as I was expecting, there should be some synovitis. So this is a left joint, and if you see on the right joint, you already saw there is a marked highly inflamed joint with so what I decided is, since there is inflammation, I decided to directly inject it because the structure of the joint is absolutely normal. There is no way there is any problem in the structure. The disc is absolutely white on white, is moving properly. The only problem was, you saw that case, there is a tear in the lateral pterygoid muscle, where it is attached anteromedial side. So I decided to inject the steroid directly inside the joint. As you can see, there's a needle going in that steroid, which was injected. And I followed this patient for almost another 6 months, where her pain actually reduced to 2. Chewing scale came down to 1. She was eating absolutely normal. And maybe because of the little bit of fibrosis, her mouth opening was 43.
When it was a challenging topic, because I frankly don't believe in surgery in TMD unless absolutely indicated. तभी तो यहाँ हुआ नहीं हुआ यहाँ पे पुणे में
Vivek, your mic is on.
which I'm not much convinced.
So 2 years post arthroscopy. So again she returned and she had the similar pain with mouth opening now restricted to 30 millimeter. And the pain scale was again 8. So I decided to do arthrocentesis again. And we did arthrocentesis of bilateral joint. 2 years down the line, first scopy, I did arthrocentesis because I thought it's just a traumatic event which happened because of the yawning. And again, I placed triamcinolone. That was the second shot after 2 years. First shot was given in actually 2 years back. Second shot, again 6 weeks of isometric exercise. Pain was reduced for almost 45 to 60 days, but again 4 years later, I mean another 2 years, and she came with the same pain. 8, 30, no clicking, mouth opening reduced, auscultation, there was frank crepitus. I mean, the joint which I saw on Wilks 2 in 4 years down the line, it has progressed with Wilks 4 in spite of all the treatment which was possible given, from starting from splint therapy to medication to arthrocentesis, arthroscopy. Again, conservative treatment was started for 8 weeks. It did not work. So I decided instead of taking a MRI, we go ahead and do a diagnostic scopy that what's happening inside the joint. And when I did a scopy, I was surprised. I mean, if you remember the joint which you saw in just previous slide, now look at this joint. This is a joint I saw after 4 years, completely shattered. There is a grade 4 chondromalacia in the glenoid fossa. This is a grade 4 chondromalacia. There is a perforation here in the retrodiscal ligament. There's a marked adhesions, fibrosis inside the joint. And when you try to move the joint, here, this bone is exposed actually. Fibrocartilage is completely gone. This is actually retrodiscal ligament. And I'll show you the condyle. Here is a perforation. This is a perforation in the, here. This is the perforation. So this is 4 years down the line, the patient has progressed from Wilks 2 to Wilks 4 without any primary arthritis. This is another joint, same condition, completely shattered joint. You can see the marked degradation of the entire fibrocartilage here. This is I mean, it was so stiff, I was not able to move. So this is actually the posterior band. That's the condyle. You can see the bare bone here. This is a condyle. This entire disc is perforated. And when I am moving that, yeah, see this. You can see here, I am moving the condyle. Here you can see the bare bone there. So now, my question to all the panelists is, now post arthroscopy, she is fine. I mean, I'm not saying she is not fine. She's her pain scale. This is after second arthroscopy. Her pain scale is reduced to 2. Her chewing scale is 3. Mouth open is still restricted. That is expected because of the condition of the joint. So now the discussion here is, first of all, the etiology of the disease. The etiology, why it all started in the normal joint. Second thing, did my steroid injection, first and second shot, has actually worsened the condition inside the joint? I mean, she was doing fine for 2 years. She has opened her jaw and she has yawned. That may be the triggering factor, but the disease process was already going on inside the joint. I mean, in spite of all the protocol, all the treatment given in a proper way, starting from conservative treatment to whatever. And third thing is, now what is a treatment option? So I think I'll start with anybody can answer this question. I mean, this is the 6-year follow-up. I mean, almost 5 years follow-up of the case, where you see that it has progressed from Wilks 2 to almost now Wilks 5. So firstly, we need to identify in my opinion, the etiology may be patient must have some sort of Wilks 1 derangement prior to removal of the third molar. And when she kept her mouth open for 1.5 hour, that has triggered the inflammatory process, and that must have created the torn in that lateral trightward. And she was eating on the same joint for another 3 years, 5 years. That has become chronic. So when I did a scopy, there was a frank inflammation inside the joint. So after that, she was fine for 2 years. Again, the same thing happened. It triggered. Yawning has triggered again. Yeah. So my question is, first is, what is your opinion on the etiology? Second thing is, do you think that use of that steroid 2 times? I have used only 2 times, and only 20 milligram for joint has actually worsened the condition. And third is now the treatment option. So it's open for all of you. I'll go with first with Dr. Vivek.
Yeah, Dr. Nehal, firstly, a very interesting case, I must say.
What do you
hear
think?
Me?
Yeah,
can you
can hear you. Yeah.
See, firstly, I must say it's a very interesting case. The reason being, when I went through.
We can't hear you.
Can you hear me?
Yeah, we can hear you.
I am being muted again. Just am I audible?
Yeah, you are audible.
Yes.
Yeah. See, I went through this case in detail. The onset, if you see, is trauma, because she has undergone a treatment, traumatic extraction, wherein her mouth was open for a long time. You treated it, brought her back to an acceptable VAS, pain scale. Then again, she had a trauma. So whatever that pani puri or whatever she was having after maybe around 2 years later, again, there's an acute trauma. So it was an arthrocentesis. Then again, she has remained pain-free. Then if we are looking at the progression of the disease, there can be a contributing factor, as what you are saying, that injection of whatever steroid, triamcinolone or whatever you have used, that can, maybe it is just an incident which is happening along the progression of the disease, which never went back to normal. She is having repeated trauma, even though you are trying to bring it back to normalcy. Then now when she has reached a stage wherein she is having major problems there, this thing is that purely on Wilke's classification, we should not base our treatment, number one. Number two, keeping in mind her age, which is just about 42.
Yeah.
I would still go with
almost 45.
Yeah, I would still go with a conservative procedure wherein either you can do a discectomy with interpositional. The joint replacement is totally not to be considered in this patient because she is just about 42 years. As of now, maybe some amount of pharmacotherapy, reassessment, maybe again MRI or your good arthroscope, and then maybe an open procedure which will be of a lesser magnitude to a joint replacement. So that is totally ruled out, the second option. First option, disc replacement with some interpositional material, is what I would go with in a case which is so long standing and it is not responding and coming back again and again with the same complaint. So that is what I'll go with.
So I have a question regarding that, your treatment option, Dr. Vivek. This is just for audience to understand. If you see the literature by Professor Mercury and even Andrew Sidebottom, the chances of success of the joint replacement decrease with the number of open surgery we do on the joint. So it's like when we do a first open surgery, the chances of success of the joint replacement reduce to say by 20%. So now there is 80% success rate. And looking at the joint condition right now, if you saw on arthroscopically, there is no way we can actually salvage the joint. We can improve the function. I have that in mind. We can improve the function. But considering the overall outcome from the patient perception, that she knows now that my joint is shattered, my joint is gone. She has been explained everything. So my question is now, do we still go for wait for the failure of open joint surgery down the line another 8 years, or do we directly
no, if you go directly, see again that yeah.
So do we still do some sort of say arthrosynthesis and we postpone the
Inevitable.
Yeah.
Inevitable. No, see, joint longevity, as I mentioned in my presentation, as compared to the orthopedic joint, you have a younger profile of the patient.
Yeah, correct.
At
I agree.
45, you are putting it, what are the, as it is the manufacturer who is saying, and then manufacturer takes it the upper limit. So if he is saying 10 to 15 years, you take it from me that around 8 to 10 years, she'll start again having some problem. Joint erosion, the polyethylene, whatever high molecular weight it is, ultra high molecular weight. Then again, she goes for another surgery. So keeping that in mind in our scenario, especially, I would still keep the TJR as a second option. Definitely not first. That's my, opinion.
Yeah, okay.
Anil, can I speak?
Yeah, sure, Dr. Chetan.
Okay, thank you. Nice case documentation here. Wonderful. I can't really contribute much for what treatment you need to be carrying on because it's a surgical aspect now. But initially,
it's not a surgical aspect, sir. What my question is, we need to give the best outcome to the patient.
That's right,
Patient is on the splint. Patient is on the splint.
Initially, I think we missed a point. If you remember, when the patient first reported, you did the scopy and you could locate, even in the MRI, some amount of inflammation of the retrodiscal tissue. You did give him a splint therapy, but you gave him a centric stabilization splint.
Yes, occlusal stabilization.
For a month or 2 months. I think when the patient was not responding, I think it would have been better if you would have changed it and given an anterior repositioning splint. What I feel is probably the patient was having a hypermobility of the joint.
Yes.
Probably glenoid was short and the head of the condyle was going out. And if the pain would have reduced with anterior repositioning splint, we should have advised the patient to make some changes in her lifestyle, like not to open her mouth too wide, so that the head of the condyle keeps coming out of the joint time and again, not to eat from the front teeth, not to yawn too wide. These are the instructions that we should be giving to the patient. Change some lifestyle so that you don't damage educate the patient that you don't damage it. From there on, it moved into a slightly over the surgical aspect and probably.
But I am still not convinced that I will jump and do, because if there is some treatment which is available, which will, we are not going to salvage this joint, but even if we can reduce the pain, improve the normal function, if she can eat, say, normal rice and roti or dal chawal, that will be the good treatment which we can give. So even if it is happening with simple splint therapy or physical therapy.
Now, what is the status currently? What is the status?
See, I did this copy in maybe Jan. She is doing good right now, but my only worry is, I know that she is going to progress again and she is going to come back with the pain. So I am just searching for the option where we can give. So I was thinking I'll just ask to start with some anterior stabilization splint before jumping.
I think it's better to just try giving anterior repositioning splint at least 5 mm anteriorly. That are where only in the night, probably 1 hour, couple of hours in the morning and evening, along with some hot water fermentation after both the affected joint, help in recovery. You can just
she's doing. She's doing since that is I asked her to use a Wolverine gel and hot water for lifetime now.
Okay.
That is the simplest that she can do.
That's great.
Dr. Bansal, any input from your side?
I definitely agree.
Yeah.
Yes, TJR with abdominal fat will suffice the treatment if you want to treat the patient. Now she is a 42-year.
She is 45 now. 46. 46.
So if you want to be, she will come with a progressive disease. Definitely another 15-20 years, she will be pain-free life. So definitely TJR should be the consider with the abdominal fat.
Yeah. So recently I was listening to Professor McCain, and he said the cases like this, you need to take a biopsy from the synovium because you do not know that there is something going on there which you may miss. This is like almost 6 years. I have a couple of cases like this, like 6-7 years progression to. They are doing good. I'm not saying they are not doing good. Only my worry is they may come up at the stage where we are. We will be exhausted with the treatment, conservative treatment, and they are young patient. I have one such female who is almost 27 now. I am seeing her since when she was almost 20 years. So she has the same history. So now at that age, when we exhaust with the conservative treatment, what is the, I am still skeptical to open the joint at this stage. Even to do a eminectomy or discectomy. So, I
Dr.
think we
Nehal,
need to do a comprehensive
Nehal,
study on.
Can we do a synovial fluid assessment, anti-nucleotide antigen?
I am trying.
Autoimmune component.
So for that, you have to standardize the technique to collect it. So what we can do is, if somebody is ready to take some, so when you inject, you take a 1 ml of saline, you push it inside, you withdraw it, you push it inside, you withdraw it, you push it. So 3 times you push it and withdraw it and sand it. So you do that before doing any procedure. You do that after 6 months doing procedure. That can conclude the things. But I think,
You will need, I think, further investigation prior to, doing any kind of surgery. That is my opinion.
See, we have reached to the era where we know that certain patient, like we know that there are a muscle component, we don't have to treat those patients. These are not our patients. We know that when there is a Wilkes 1 and 2 or 3, maybe they will get rid of this problem with just conservative treatment. We know that if there is a 3, 4, 5, but you will encounter the patients like this, say they are 2 or 3 patients, but they are young patients where we need to deliver them, because that's the last hope they have.
Quite that is why we are having an entire evening on TMD management, either conservative or surgical. The gray area continues to be gray.
But sir, I think it is going for TJR maybe sooner or later, because whatever we do, ultimately, if she is not living a good life for next 4 or 5 years, we are waiting that she becomes 50 and then we put a joint. I think we are losing 4 years of her good life. So,
but Abhi, she is asymptomatic, na? Abhi, she is asymptomatic, Dr. Nehal.
What?
She is asymptomatic
she
right
is
now.
Not. It is like, how do you define symptomatic?
Okay.
So on vast scale, pain is say 3 to 4.
Okay.
Chewing, I don't think vast scale she will put less than 5. CK node, normal diet, soft diet, and the mouth opening is, of course, it is like a 30 millimeters. So it is going for basically fibrous ankylosis if you don't mobilize the joint. So she is on continuous isometric exercise. She is on continuous on the heat fermentation. Yeah. So
Nehal, I think you can try anterior repositioning.
Yes.
With some good isometric exercise, and also you can prescribe probably something like pregabalin, max galin M75.
Methotrexate has shown some
she is
promise.
taking almost for 6 months now.
That's the only thing which can help keep her in
now
good
she's into
state.
post-gabalin. She's post-gabalin now.
Can I comment at this point, sir? Ashish, sir, may I have a small commentary?
Yeah.
Sir, I have one small query. Normally, as so far the discussion on this case is going, a fantastic case to discuss, I'm sure. But as far as we are discussing on the symptomatology of the patient only. Can we get down to the diagnostic aspect first? Yes. Because I have one thing in mind why I'm getting here is because this patient is around 40s, in her, as you said, 45 now. She also falls into the criteria of being in reactive arthritis. Did we rule out the possibility of reactive arthritis? Because we are constantly calling it as level 5 Wilkes, but a lot of characteristics are the signs and symptoms.
That is common. This is basically arthritis. This is basically progress to arthritis.
This is progress to arthritis. So because 100%. There is flattening, there's a lack of fibrocartilage, there is pain, there is, I mean, all the features of, but yes, we have not gone towards the other joints of the body. We have not seen that whether.
No, that has been evaluated, Rohit.
Okay, sir.
I mean,
Okay.
I have done a orthopedic consultation, rheumatology consultation for this patient.
Okay,
have
that has been
serology-
covered up. Okay,
they have
that has
ruled it
been
out.
covered.
That
Okay.
her serology was done, complete serology for
Yeah.
primary arthritis, SLE, everything is done.
So where do we diagnose this as? This is this. What do we call this patient? Where from
I call
diagnostic
it
perspective?
arthritis, progressive
call it
arthritis.
arthritis.
I call it the progressive
Osteoarthritis or
arthritis.
degenerative arthritis.
Secondary to the macrotrauma.
Osteoarthritis.
Now, what you are planning, Nehal?
I am not planning anything. That's why I put
He's
this
still
case.
holding on. Yeah,
Yeah,
that's a wiser
I think
thing.
Rohit, it is. I am considering there is osteoarthritis.
But I think anterior repositioning splint might work for some time, and then you have to go ultimately for replacement.
No, my question still stand. Do you think that that 2 dose of steroid has triggered this? Because I have read a lot of literature nowadays. Is that
2 doses will
Even-
not cause that much of harm.
but there is a literature in the orthopedic that says a single dose of steroid in some individual can trigger the chondrotoxic activity.
Yes,
And-
we have discussed this, sir, earlier on that group also. I think last year there was a strong discussion on single dose versus multiple dose of steroids. So it's more of your conscience which is making you think that. It may not be the cause in this case.
I know, but see, I mean, you see the evidence of the progression, right? Now we have a progression evidence that she has progressed from synovitis till now almost the joint which is Wilks 5. So, I mean, we have to put all the dice on the table that what is happening there. So ultimately, I think I'll end up doing a biopsy to rule out some, what you are suggesting, like some histopathologically something is going on. I mean, that's the thing we can do now.
Great. Very nice.
Can we try injection hyaluron once in a month and along with the collagenopeptide before planning to do something for surgical?
I think it's much beyond that. I think it's much with the chronicity. I think we are beyond that stage of intra-articular or something. I think, I'm sure Dr. Neil must have tried all that, but I think we are beyond that in this case. With the chronicity of the case, I think the options are pretty limited in this. You have done an entire evaluation from the orthopedic, rheumatologist, endocrinologist, serology. So I don't think that it's like going back in the treatment algorithm. Dr. Nehal.
Yeah.
So no,
I think we will just keep on. I mean, if there is some progression, I'll update everybody.
Yeah, please do. I will catch up on WhatsApp.
and whatever you are doing for this case, kindly update. Huh?
Yeah, it will be very interesting to know.
Okay. So I think
Yes, there is one question that what about the intra-articular injection of opioid? I have tried that, buprenorphine. Does work, but it has a limited
time period is small. It will work for a short period.
buprenorphine. We have done a study for almost 30 patients now. It does have a good effect, but then the only thing I use for arthroscopy is a simple ringer lag thread without any medication.
Patient is symptomatic, very severe arthritis. I find tramadol or or morphine, any injection you add in, so definitely works.
It's a intra joint.
When we are lavaging, I mix the tramadol hydrochloride 50 milligram in 100 ml and lavage or either morphine. That also improves the VAS scale compared to the plain arthrocentesis when there is something idiopathic EMJ arthritis cases.
Okay. I'll update you.
Can we take 2-3 questions now?
Yeah.
One question to Dr. Chetan. Somebody has asked, how much are the edentulous space responsible for this kind of problems?
The posterior Pedunculaar space does cause issues with changes with intra-articular pressure. So, whenever you come across a patient who's got pain, especially in the joint, who's got missing posteriors, first you replace the missing posteriors. Just give him a simple RPD or something like that. Try to re-establish the occlusal plane. It might, if it relieves the pain, that's about it. Then there is nothing much to be looking for. But if it doesn't, then you have to evaluate further.
And somebody asked how long you should wait for anterior repositioning splint to work. Means when do you say that it is not working?
2 months is a minimum time. Anywhere from 15 days to 2 months time, it should start giving results. In 2 months time, if it doesn't show results, that means very most often it is not working at all. Because 2 months is quite a bit of a time where the head of the condyle is held anterior and retrodiscal tissues are devoid of excessive load, and you are given enough time for the retrodiscal tissues to recover. In 2 months time, if there is not recovering and the pain is not coming down, that means certainly it is not working.
Dr. Nehal.
Yeah, it's like, see, any treatment which does not work for 6 to 8 weeks, there is no point in continuing with same treatment repeating again and again and again.
Right.
Sir, there is a article by Davis in British Dental Journal 1997, which clearly states that the anterior repositioning splint has to be kept for at least 12 weeks. This article is titled The Pattern of Splint Usage in the Management of Two Common Temporomandibular Joint Disorders, Part 3, Long-Term Follow-up in an Assessment of Splint Therapy in the Management of Disc Displacement with Reduction and Pain Dysfunction Syndrome. This is volume 183. I incidentally happened to present this over somewhere, and I just thought I'll just add this to the discussion right away.
Okay. Nehal, what is the role of vitamin D in internal derangements? Do we have any role of vitamin D?
No, I mean, if you consider as a soft tissue, I don't think there is a role, but yes, I mean, overall treatment, when you are treating this patient, we do check to evaluate the primary arthritic, or say, we do check for the vitamin D, and if they are have a deficiency, yes, we do start with the vitamin D therapy. I don't think the displacement of the disc has any role with the vitamin D.
Okay. Dr. Vishal Bansal, what would be the role of arthrocentesis in chronic disc displacement cases?
Ashish, I cannot hear you.
What would be the role of arthrocentesis in chronic disc displacement cases?
Yeah, definitely we should try once at least, because there is something called recapturing phenomena. It works most of around 6 cases among the 10 cases. It works very well. Lavage and putting in a hyaluronic acid and splint and adjoint during the arthrocentesis, manipulation of the jaw movements helps in, and that is also Murakami also reported the recapturing phenomena. It works. At least if you are not going for arthroscopic surgery or open joint surgery, one chance can be given, and it is effective more than 50 to 60% cases.
Great. And what next if patient doesn't respond to arthrocentesis at all in any case?
Yeah, definitely arthroscopically or either joint disc repositioning if there is a joint no destructive or no degenerative changes.
Okay. So I think we are done. There were so many questions which have been answered on group by Dr. Vishal, Dr. Rohit, all they have discussed on group. I think we must wrap up now. It's already 3.5 hours, and fantastic session we had today. Dr. Vishal, Dr. Nehal, Dr. Chetan Hegde, and Dr. Vivek. It was wonderful to have you people around, and a wonderful, wonderful session for all of us. And I would like to thank all the participants along with our Delhi NCR chapter members. They kept waiting for this and they were there whole time. And thank you very much. I will fail if I do not thank Praveen from A1 Logistics, Logics Bangalore, and our head office, because we are using their platform for our webinars. Thank you so much. Thank you, everyone.
Thank you very much, sir. It's been really nice interaction as well as deliberation. Nihal, thanks once again. Dr.
Thank you.
Bansal and Dr. Chetan. See you around, all of you. Thank you, Dr. Ashish. It's been really wonderful. Thanks a lot for giving this opportunity. Thank you.
Thank you all.
Thank you very much. Thank you,
Bye.
everyone.
Bye, everybody. Signing out.